Greetings, everyone. Good morning, good afternoon, and good evening, wherever you are. It's my pleasure to welcome us all to our virtual meeting for this year. The disruptions created by the COVID pandemic means that we are unable to meet physically, as has been our practice in the past few years. However, these disruptions obviously are not going to stop us from coming together to discuss and plan what we need to do to ensure that every child anywhere and everywhere in the world has access to high quality and timely surgical care. The meeting has been planned over the next 2 days. We are going to be discussing, reviewing all that we have been doing and planning what we need to do going forward to continue our progress, to build on what we have achieved over the last several months and the last few years. The program is quite packed and is designed to be as interactive and engaging as possible. And I encourage all of us to engage and to make our contributions in all the aspects of the various topics and sessions that we are going to be going through. So I welcome all of us, and I encourage you to sit back and enjoy the meeting as we go forward. So thank you very much, everyone, and welcome to this year's GICS virtual meeting. Welcome.
Well, hello, my name is Marilyn Butler, and I am available for any technical questions that you might come up with over the next 2 days. It's easier if you just send me emails and I'll periodically check those, or send me a direct message in the chat and I should be able to see those. I had originally thought that we would need to pre-assign everyone to breakout rooms. So thank you everybody who sent me the preferences for the breakout rooms. I think I figured out a way, or I didn't figure out a way, someone told me how to figure out a way to have people select their breakout rooms on the day of. So hopefully that will work well this afternoon or later this morning when we go to the breakout rooms. We'll so no need to send me any more of those preferences for the breakout rooms. We'll be okay with that. Just wanted to give a little introduction about our membership to GICS, and let me share the screen. Basically, in terms of being a member of GICS, we certainly welcome everyone to join our meetings and join our webinars and so forth. But if you were to become a member of GICS, you'll be receiving newsletters about our activities. We have a password protected website where you can converse directly with other members, and you can be involved with our committees and working groups, which are the core of our activities. When we do go back to having meetings in person, we are proud that we're able to subsidize much of the travel for our LMIC colleagues, and as a member you would be eligible for those funds, and obviously you'll be connected to a large group of people who are passionate about children's surgical care. The membership fees are scaled based on what you're able to pay, but the key thing is that our membership is meant to be inclusive, and if fees are a hardship, then we certainly will waive them. If to become a member, just go to our website, which is gicssurgery.org, and you'll see a bit at the top that says Join GICS, and then if you press that, it'll take it to our membership software website, and you can at that point pay dues and converse with us, and if you need those dues waived. So with that, I'm going to stop sharing my screen and introduce Keith, who's going to give us some updates. Just
Good
a
morning.
moment. Yeah, I'll Keith, by the way, I just want to admit a few people from the waiting room, and then I'm going to share the screen with your PowerPoint. So hold on just a moment. Okay. See, sorry about that. I had two PowerPoints up at once, and so that was confusing it. Okay.
Thank you, Marilyn. I'm glad you're doing the electronics part of this rather than me, so we have a fair chance we'll get through it. So this will be fairly brief. To be clear, I'm speaking to you from the States. Good day to everyone, wherever you are. My job was simply to briefly review the leadership of the organization. I was personally part of the initial organizing committee and then the board, but I'm no longer on the board. So these individuals are our past chairs. I can't actually see from my screen whether they're with us. I know Kokila is. So Diana Farmer was our initial chair of the board, followed by Kokila Laku, and currently, of course, is Professor Ame, who you just heard from. Also on, and I know all three of these individuals are on the call in the meeting now. Daruk Asgadis is our chair-elect, and he will assume that position July 1st of this year. Zippy Gathua is our secretary, and Marilyn Butler is not only our treasurer, but our host this morning. Thank you, Marilyn, for organizing all of this. Next slide, please. And this is our current board. The terms, I think people know, are designed to, there are 3-year terms that are offset so that there's a incremental rather than a large transition each year. There will be new board members selected in the near future and announced, but our current board members are the ones that you see here. On the left-hand side of the screen, we have that with terms that will end this year. These are renewable terms potentially, but these are scheduled to end. Tamina Banu from Bangladesh, Steve Bickler from California, Dan Pinaro from Montreal, and Sabina Siddiqui from the US. I know I saw Sabina on earlier. The terms that are scheduled to end in 2023, a little more than a year from now. Mildred Chitnis, South Africa, Richard Stewart from the UK, Sarah Greenberg from the US, Hafiz Abdel Hafiz from the US and the Sudan, and Abdel Basit Ali from Sudan. And the final group that whose terms are scheduled to end a little in 2024, you see Olambuni from Nigeria, John Sikabura, Uganda, Risha Maduri, India, Laura Goodman, US, Faye Evans, US, and Simone Abib from Brazil. So that's your leadership team. I think probably most of those people are on the call and will be interacting with all of us over the next couple of days. Let me just simply add my welcome to everyone, and thanks to all of you for joining us. Marilyn.
Great, thank you so much. All right, so I think, Emmanuel, did you have any other comments before we go ahead to begin our first session, the working group updates?
No additional comments. Thank you.
All right, so Abdel Basit, if you want to go ahead and Ruth, you could go ahead and start, just put that first slide up, and then Abdel Basit, if you could just introduce yourself, then we'll proceed with our first session. Thanks all. Welcome to everyone. We have now 113 people.
Thank you very much, Marlene. Good day, everybody. I'm Abdel Basit Al Said Ali. I'm a consultant pediatric surgeon, currently based in Saudi Arabia at King Saud Medical City in Riyadh. And I would like to welcome you for this first session here in our meeting. And this session actually consists of streamed recordings of lightning presentations by leaders and representatives of various GICS working groups. And at the beginning here, we have 6 presentations under focus areas, and it's stream recording. So can we start, please?
Ladies and gentlemen, good day. I'm Abdelbasit Said Ali, a pediatric surgeon, and I'm going to talk to you on behalf of the GICS Pediatric Trauma Working Group. Trauma is a common problem globally with profound health and socioeconomic impact, and it is alarming that 95% of the leading causes of injury and 98% of deaths from trauma in children take place in the low and middle-income countries. Pediatric surgeons and surgical subspecialties are all involved in children's trauma management, mostly as a fragmented service. And many organizations work in close collaboration through advocacy, provision of adaptable training templates, and equipment to LMICs. So who cares for trauma in children? We all care for children with trauma, but what most of us lack is to care for trauma care for children. In other words, care for system development and capacity building for children's trauma care. In this regards, GICS has proposed a children's trauma care initiative to address the problem of pediatric trauma comprehensively and the methods of management globally and in the LMICs in particular. And here are some of the leading figures in the GICS trauma working group: Durok, Simone, Kokila, Soji, Norman, and Charles. The initiative is designed to have a global coverage, cooperation, and collaboration with sister societies, associations, and organizations working to achieve the same goals through invitation, encouragement, and engagement with local champions to adopt, adapt, and implement the initiative within their prospect and capacity and facilities. A simplified practical approach was designed to address the various aspects in relation to trauma, such as prevention, primary care, in-hospital management, specialized surgical services, through to registry, guidelines setting, and specialization in pediatric trauma. The activities of the Pediatric Trauma Working Group. The group has produced simplified trauma prevention leaflets that are available for translation to different languages and are uploaded in the website. We believe that prevention is better than cure. Regarding training, a one-day children's pediatric trauma course has been prepared as a modified version of the primary trauma care in collaboration with the Primary Trauma Care Foundation. And the group addressed the 4th GICS meeting in Johannesburg and the 75th United Nations General Assembly meeting with information about the magnitude of the problem and proposing recommendations. The group also addressed other activities such as the Norwich meeting symposium and also the second online PAPSA, Pan-African Pediatric Surgical Associations meeting with talks about prevention and studies on trauma in Africa. The group has also been participating in preparation of a module for WHO and in setting guidelines in collaboration with the Pediatric Trauma Society in the United States. Finally, there is a genuine need to draw attention of all stakeholders to the importance of proper training of healthcare workers and allocation of funds to hospitals and all healthcare facilities that provide pediatric trauma services to manage this non-discriminating, potentially avoidable, devastating, disabling, distressing problem. At the end of my talk, I would like to invite you all to join our working group, and here are the addresses. Thank you very much.
Good morning, good afternoon, good evening, everybody. My name is Hafiz. I'm a pediatric oncology surgeon and the lead of the tumor working group. In the next few minutes, I'll highlight some of the focus area of the group, including evidence-based guidance for oncosurgical management and education. To help disseminate pertinent oncosurgical management principles that are resource sensitive, we conducted multiple oncosurgical webinars and workshops in few LMICs, focusing on challenges in the management of index solid tumor. In the pillar of evidence-based surgical guidelines, we recently published a need assessment for standardization of surgical care for Wilms tumor, and followed that with the development of evidence-based guidance as an output of multidisciplinary panel that unifies major stakeholders within the pediatric surgical oncology community and uses an evidence-based methodology to provide resource-conscious recommendation for surgical management of pediatric Wilms tumor in limited resource setting. Recommendations were developed following the grading of recommendation assessment development and evaluation methodology. The guidelines development group was consciously structured to balance content expertise, gender, geographical representation, and included the patient advocate. The guideline scope and priority topics were drafted, refined, and feedback was obtained from stakeholders to reach consensus. Identification of primary critical outcome and primary topics and formulation of related PICO question then followed. This was followed by retrieval of evidence through specific systematic reviews of each topic using an agreed standardized methodology, and followed with assessment and synthesis of the evidence, formulation of recommendation, writing, and dissemination. Currently, there is also multiple other ongoing exciting projects, including standardized surgical report led by Simone, Derek Harrison, and Kukila. Another project that is ongoing is GICS Pediatric Surgical Oncology Resource Assessment Questionnaire led by Christy Grant. Vascular Access Situation Analysis that is led by Jaime and Simone and should lead to development of a clear guidance. Tumor board impact on surgical results. This project is led by
Greeting you all. I am Mariam Qawamiyadeh, pediatric surgeon from Iran. On behalf of Professor Tahmina Banu, I am going to present the congenital anomalies update. The first one is about global survey of fetal ultrasound screening for congenital anomalies. It was supervised by Professor Kokila Lako and Nailish Tank from India and Ben Martin from UK performed it. Survey circulated using the mailing list from GICS, UPSA, ICBD, SR, and YAPS. 2 obstetricians, neonatologists, and midwives through Twitter and Facebook, and draft manuscript is being prepared. And also a survey about top 3 common birth defects in the clinical practice has been performed and led by Professor Tahmine Banu, and the survey will be sent to GICS membership until end of the March 2022. It is prepared by Shilpa Sharma from India, Mohammad Amjad Chaudhary from Pakistan, Felicity Vidya Mehendel from UK, and Catherine Klofberg from US. On March 3, 2021, the World Birthday Defects Day, a panel with care providers performed about saving lives and newborn screening and care, and Tahmina Banu was one of the panelists. Thanks for consideration.
We're glad to present to you updates from the Education and Training Committee. My name is Phyllis Kisa, and I'm a pediatric surgeon and lecturer at Makerere University in Kampala, Uganda.
Good morning, I'm Dr. Siddiqui. I am a pediatric surgeon and an associate professor of surgery at Arkansas Children's Hospital in the USA. We're very honored to be able to update you on what the Education Committee has been able to accomplish despite the pandemic in the last 2 years, as well as offer our projected plan of offerings for this upcoming year. This will include a reflection on what we were able to do with the education repository, including the interim report on our need and gap analysis, as well as the content that has been developed over the last 2 years. We will also project some information about the virtual grand rounds we hope to offer this year, as well as the journal club that we are offering and willing to support. The education repository has been in process since the last time we met. In the interim, we have put out a survey to better assess what the needs and the desires of our membership is. To date, we've had 18 respondents, of which over 75% are pediatric surgeons, majority of whom are looking for further training, and particularly in the pediatric surgical subspecialty. If you haven't taken the survey yet, please click the link that's available in the chat so we may better understand how to address your needs.
In Uganda, we have run a pediatric emergency surgical course since 2008 and 2019. We're able to run 3 courses, and since then, we've been unable to run more courses due to the pandemic with COVID. With this course, other centers have requested for the course material from other countries, and we're happy to share it, and we hope it will be part of the GICS repository. We're also in the process of developing a course manual and developing course content to include nurses and pediatricians for early patient identification. The course is currently undergoing an impact assessment, and we hope that information from this will help us make a better course that makes it adaptable for other settings. In other educational efforts, in an initiative by Kids OR and in collaboration with the Royal College of Surgeons of Ireland, the West African College of Surgeons, and the East African College of Surgeons, a Pan-African Pediatric Surgical e-learning platform was developed with authors from Africa for Africans, and trainees from the West African College and East Africa have been using it for about a year. We recently had a debrief meeting of both authors and trainees, and the trainees appreciated most the modules on non-technical skills. There's still more modules being produced and in development phases, but there's a need for more authors and editors as well. Please feel free to contact us to be able to help this effort.
So in addition to these really great opportunities, we are hoping to launch in the spring the GICS Virtual Grand Round, which will consist of an expert panel of surgeons and anesthesiologists and critical care physicians who will address case presentations that trainees will bring to them. CME will be offered with this process, so please keep an eye out for this. We also are offering support for folks to host a local virtual journal club. This is modeled after the journal club that Dr. Maduri has produced through her CMC Valor experience. please reach out to us and we will help offer you the model as well as technical support as needed. With that, we are very pleased to have brought you these updates. There will be an education committee meeting in the near future. Please click the link in the chat box or email us to learn more and offer participation.
Hello, I'm Dan Panaru, and together with Prof. Prisha Maduri, we lead the research committee. This committee has been in existence from the very beginning of GICS, and it is quite central to its activities because we do believe that all our advocacy work and equity work needs to be based on evidence, and encourage very much our members to be involved in disseminating knowledge and generating new knowledge through research. What have we done over the years for that purpose? In the first place, we have run several research workshops during our annual meetings. These workshops have been very successful, very subscribed, and well evaluated, although it is hard to know what direct impact they had on the research productivity of our membership. And it is because of that that we have decided to also offer direct individual assistance to our members, especially young academics from low and middle income country. We offer support for protocol design, for research methodology, application for research ethics board, and grant assistance as well. We also offer more formal research supervision for anyone who is interested in this. Several of our members, in particular Prof. Lakou, have been able to bring and offer research programs for some of our members in order to foster this research activity. And finally, we do liaise with the publication committee, not only to ensure good quality of publications that is vetted by GICS when this name is included in the publication, but very much to ensure that the values and principles of our initiative are reflected in any publication, as well as surveys and other research projects that wants to affiliate itself with GICS. So that's what we do. And in terms of the future, we want to encourage very much members both to join our committee, to be involved in these activities and new activities that we hope to set up, but also very much to remember us if you have any research questions or want to have assistance. We don't have a lot of funds as such, but we do have many people who are delighted to work alongside any researchers so that we can create the quality evidence that can then support all of our work globally. Thanks very much.
Good morning. Thank you for allowing me to briefly tell you about the importance of family within GICS. Just a little bit of background. I am both a pediatric surgeon and a mom of a child born with esophageal atresia. And to have a child born with a surgical correctable congenital disease, especially if the surgery needs to be done in a neonatal period, is definitely an emotional roller coaster. Your family and the support of other parents is what you're going to get through this. We had a small informal WhatsApp group, and then through the guidance of ETH and Tufts in the UK, we ended up starting our own official support group for esophageal atresia in South Africa, and it has really made a difference. These are just some of the kids that belongs to our support group. So support groups are really important aspect of the treatment of surgical correctable diseases. It helps with the emotional well-being of the patient as well as the families, and in the end, it does improve the outcomes. There is some literature to back up what I'm saying. In 2008, an article was published looking at the social and emotional support and its implications on health, and it's found that it's definitely protective for certain conditions. In 2014, Natalie Struble, on the other hand, did a PhD looking at what the social benefits are for volunteer support groups, and found that it's definitely of a benefit in the fact that it reduces isolation. People with the same condition that's been through the same emotional roller coaster can talk to each other, they can relate, and they can give each other emotional support and advice that the doctors or the surgeons can't always offer. It increases the social networking, and in the end, it helps obviously to build relationships. Looking specifically at esophageal atresia, but this can be tracked to any surgical correctable disease. Kaplan came to this conclusion that psychological morbidity associated with esophageal atresia or any surgical correctable disease has important implications for clinical practice. If psychological support is being offered to parents during the neonatal period and then continued as part of the long-term follow-up, it definitely improves the overall outcome of both the parent and the patient, and in the end, decreases the biopsychosocial morbidity. And I think this is very important. So what is the function of all this that I'm talking about within GICS? So if you just Google support groups, lots of support groups come up. Some are official organizations, NGOs, nonprofits, and others are just Facebook support groups of parents. Whatever it may be, there should be a place for each and every parent going through this, and they should be able to link to this. So I think it's really important to have a working group where we don't try and reinvent the wheel. We should share information that's already out there. So don't start your own brochure about Vactrol if there's already a Vactrol brochure out there. Don't start an organization in Uganda if there's already an organization for that disease in Uganda. Let's all rather work together. On the GICS website, it would be great if there can be a section for support groups. People click on it, say esophageal atresia leads you to EAT, and EAT gives you all the support groups in the office of esophageal atresia that belongs to it, and you go to the one that's either in your language or in your country. The same for CDH or for NEC for Hirschsprung's disease. We all link together and we work together. It would also be nice if all these support groups can nicely come together and we come up with inventive ideas to reach those people that don't have support groups or that are in low-income countries where internet is not that freely available or where English is not their first language, so that we also give them the opportunity to have this emotional support from patients and parents around the globe. In the end, I think it's important that we provide support to all children and their families, especially if they have surgical correctable congenital diseases, and even more if it's in the neonatal period. So just in summary, I cannot stress enough the importance of support groups. It is really an important part of the overall recovery of both the patient and the family. I think it's important that it's parent or patient-run support groups are not run by the medical fraternity, but it should work closely together with the physicians and the surgeons, because in the end, we guide the parents guide us towards the correct treatment plan, but we are also there to provide information. All patients should be referred to this group by the surgeons or the physicians, but in the end, I want everyone to work together. All support groups from different countries, different diseases, so that we can end up providing equal support to all, whether it's in a low, a high, or a middle income country. Thank you very much.
Thank you very much. Thanks to all the speakers. If there are any questions, They can be either put in the chat box or you can unmute yourself. Those who have questions. Sorry, may okay, it is good to see that many of the speakers, many of the comments there in relation to the presentations are raising the point that we do not need to reinvent the wheel. I think this comes in a lot of our activities in these GICS working groups, particularly when it is related to the sorry for that. When it's related to the low and middle income countries, because a lot of material is available there that just needs to be translated into real actions, depends on the available facilities for each medical community. Are there any questions?
Hi, we have a couple of questions related to the different sections. It's divided up in the chat questions, but for the trauma update, we're curious what was involved in the one-day trauma course. Was this didactics and hands-on, and then was this course in person or online?
Yeah, thanks for the question. In fact, this has been prepared in such a way that it's to be like a half day within the meetings of the GICS, the future meetings, when we come together in person with physical attendance. And so far, we have not gone into the details of how the course should run, the number of people who will be there, the facilities for it, the technical requirements, and the method of giving CME points for it. It is still in the process of taking shape, and we are in contact with the Primary Trauma Care Foundation to try and resolve the issues of how the course should be done, because it is derived from that main course. So that will all come when we prepare for the next physical meeting of GICS, but it's planned to be like a half a day course, essentially in form of sessions and maybe hands-on training. Any other question?
It looks like we have another question in the chat. Psychological support is absolutely beneficial and necessary. The network and access to support groups is so critical for recovery, but many do not know what resources are available. Did I hear we have a network that highlights this on the website? We may be able to look at tools and support with translation.
Yeah. Any response to that from Corny, the host?
Yes. Thank you for the question. We're still very new in this, and we're only starting to do a setup now, but the plan is that we will work with GICS and have a special link on the website that will go to your specific disease. So if it's congenital diaphragmatic hernia, you'll click on it, and then from there you can sort of choose your independent support groups. The same with esophageal atresia and anorectal. So we're working on that, and hopefully it will be part of the website soon.
Okay. It is also nice to see this integration of the required services for a comprehensive approach to the management of pediatric surgical problems when it comes to having educational program and family advocacy. So all that comes together with the aim of giving the utmost to our patients. With regard to the education program, Sabina and Phyllis, is there any coordinated form of training program run in any place, or is it just allowed for the people on the ground to just attend your sessions and then deal with it as tutorials and as academic activities with no actual physical training on the ground?
If I could answer that first, I think it depends on the courses that you're doing. So if you're doing, for example, the emergency pediatric course in Uganda, when we run it, it's a physical course. You go to a specific hospital and you teach them at that site. And if there's cases to do, it's done there. But then when it comes to the PAPSEP course, for example, the RCSI Kids OR modules that's been used by WACS and COSEXA, it's the online modules, and if you have an internet connection, you'll be able to access it. Now, so far, the access has been for pediatric surgical fellows in the EXA and WACS regions, and but certainly there's a question asking whether it's free and if anyone can access. Yes, it is a free module. And if you're interested, again, we listed our emails and we can share it again. You can contact us and we'll link you to RCSI that manages the site to get you a user login, and you can take part in the modules and some of the discussions that might be. It's not yet translated, it's still in English only and not in either Spanish or French or any other languages. So it's limited for now, but I imagine that in the future it may improve. I hope I can, Sabina may answer some of the, or have a comment. Thanks.
Another question that came up for the tumor section, well, two questions, but do you think there should be designated pediatric cancer hospitals, or is this unrealistic? And then are there any international pediatric tumor databases?
Excellent question, if I may answer. There is a case for centralization of childhood cancer care due to the complexity of the care, the multidisciplinary requirement for it, the high diagnostic capacity that is needed for it, and also therapeutic and treatment capacity. But that model works only if there is good health system integration. So in the absence of health system integration, then having a really high capacity centers only in the capital will not resolve the problem, because many children will not have access to that center. So it goes side by side, trying to centralize but also trying to integrate healthcare, work on early diagnosis and referral pathways. That's on sort of a summarized answer to that question. In terms of data and registry, we really have limited data available, because the vast majority of countries around the world don't have national registries. There is some hospital-based registries, obviously in high income countries there is national registries, but overall the vast majority of children with cancer live in the low resource setting. Therefore, we don't have national data on that setting, unfortunately. There was another question maybe about COG, PSYOP. Obviously, that there's a wealth of experience from the COG and PSYOP, and these are really massive, big research group that provides research protocol regularly. And on the current PSYOP protocol, there's some new research question to be answered and all that. But I think that when we are designing guidance for limited resources, we tend to take a different approach. The approach will be generally based on the resources, the priorities outcome, and then what are the sort of, challenging questions when we make these questions in a PICO format and try and answer them in a sort of a scientific, systematic way, and also obviously through expert consensus. I hope that answered the question. Thank you.
Hello, this is Marilyn Butler again. Is a great discussion, and there's still a lot of questions in the chat, and we will look forward to continuing the discussion either offline or in our breakout sessions later today. But I think we need to move on to the next session. Thank you to all who participated.
Thanks, Madeline.
Hi, my name is Hafiz, and I'm a pediatric oncology surgeon at St. Jude, and I'll be moderating the specialty working group together with Chisholm. So we'll basically go through all the specialty working groups and listen from the leaders from general surgery, pediatric surgery, anesthesia, neurosurgery, orthopedics, surgery, cardiac surgery, ENT, urology, nursing, and trainee group. So without further ado, we'll hear from Basil Lieu from general surgery group.
And unfortunately, Basil's talk did not come in time, so we'll start with the second talk instead.
Thank you.
Good afternoon. My name is Adesoji Ademuyiwa. I'm a pediatric surgeon working at the Lagos University Teaching Hospital, Nigeria, and I shall be representing the specialty working group of general pediatric surgery in this report. So we left Johannesburg in 2020 with a lot of excitement, hoping to hit the ground running. But as Michael Altschulzer said, the bad news is that time flies. However, there is a good part of the news, which is you are the pilot. We had planned writing for the special edition of Frontier Pediatrics, and we left with excitement, many of our members trying to contribute their quota to that edition of the journal. Then COVID happened, and every other thing literally stopped. However, in spite of those challenges that we've had, our group have been able to contribute to the COVID literature and information. The first being the invitation I had to be part of the webinar on mitigating the impact of COVID-19 on children's surgery, which took place in June, and a second one which took place in July. Unfortunately, I couldn't partake of that because I was down with COVID at the time. However, that has now been published, and it's one of the things that we could say we did during this period. The second paper that came out from our group was led by Dennis Mazingi and his colleagues, George and Catherine. They were mentored by Professor Kokila Laku and myself. We were able to do a review of how to mitigate the impact of COVID-19 in Africa, and that was published in BMJ Global Health. and was also well received. Because of COVID, as you'll imagine, not much could be done in respect of research outside of COVID. But we have since decided to have a database for members of our group, and that we'll be discussing more at the breakout session. And for those of us listening to this presentation, the link is there, and that can also be shared for you to give in your details for us to have a database. Early responses from the forms is what you have on the screen. The people responded to the singular most important thing that our working group needs to be more impactful. Some feel that we need to get the young medical student trainees and junior consultants to be involved in GICS. Others feel that we need a central online database for inputting all data locally and then using them globally. Others feel we need, as a working group, to have regular meetings to exchange ideas, while some feel we need to define what the workforce, the facility, and disease burden in low and middle income countries are. And another feel training of personnel. So some of these will be things that we will have to discuss at the breakout session. I think I have 4 minutes. I've overshot by a minute. I'm sorry. Thank you very much for listening.
Orthopedic Subspecialty Group of GICS meets regularly once a week. This is in the form of its main activity, which is the Weekend Journal Club. This journal club is open to all children's orthopedic surgeons without access to such institutional activities. Takes place once a week on Saturday, and duration is 1 hour. 2 to 3 articles are read in current journals are read at each of the meetings, and it uses a Zoom platform for interaction. Though we have 11 members on the roll for this particular journal club, usually about 6 attend at one time. All members are allotted topics or can choose current topics and present. Discussion is open to all. All children's orthopedic journals and pediatric section of orthopedic journals are covered. So we have had in the last 1 year 2 publications related to this activity. One is actually the description of methodology and the benefits of this journal club, and this was published in the Annals of Surgical Education, with the participants at that time being the co-authors. And the second was an article in Journal of Pediatric Orthopedics America, criticizing one of the major articles on Perthes disease, which was published by members of the Perthes study group. We also in future plan to have systematic review, and the topics that have been already suggested are bone and joint infection in LMIC and supracondylar fractures of the humerus in children in LMIC. All those who are interested can please join us for the for the orthopedic session and at the end of the day, and where we'll be discussing this further.
Thank you for the opportunity to present at the Global Initiative for Children's Surgery webinar this year.
I will present the work of the Cardiac Surgery Working Group. My name is Bistra Zheleva. I work at Children's HeartLink, where I'm the Vice President of Global Strategy and Advocacy. I'm probably one of the few non-clinicians here, but I have been in this field for 18 years, building capacity and advocating for pediatric cardiac services in low and middle income countries. The Cardiac Surgery Working Group was started in 2018 after the meeting in Vellore. We had a number of conversations during that year, and we stopped because of lack of personal capacity on many of our sites. But we resumed the conversations in 2020, and in 2021 started working on the guidelines on the recommendations for pediatric cardiac programs. And the goal from the very beginning was to develop 3 levels of recommendations for pediatric cardiac services, a roadmap of infrastructure and capacity needs, and recommendations for facilities, as well as recommendations for governments. I'm not going to go over all the members here, and some have been more active than others, but on the right you see everyone who has been involved one way or another, or invited to the group, but on the left you see the current active group and the people who actually develop the first recommendations that I will share with you. Arish Bhatti is a medical student, and she worked under the mentorship of Dr. Babar Hassan, who is a pediatric cardiologist, and also worked closely with Munir Amanullah, who is a surgeon at Aga Khan University, and myself as well. So we developed the global, what we call the global recommendations for development of pediatric cardiac services, or the minimum necessary requirements for a pediatric cardiac program. We received input from certainly the people you saw earlier, GICS member leadership. We also invited input from the Global Consortium for Children's Hearts, which is a group loosely organized by a number of NGOs similar to the organization I work for, Children's HeartLink, and the Child Health Task Force, which is an organization that brings together practitioners in global health that specialize in child health, including people from funding organizations, UNICEF. How much they looked at our guidelines, I'm not sure, recommendations, but they certainly did receive them and had an opportunity to comment. When we were developing these recommendations, we wanted to see what different levels of the health system's facilities were, and so we ended up using the DCP-3, loosely based on the DCP-3 recommendations, and you can see some of the examples here on the right. But what we wanted to represent is really, we're not looking just at surgical services, but we are looking at all the services that need to exist in order for a surgical program to be developed and to be well functioning. And so this is, I think, these guidelines have been formulated for cardiac surgery programs with the challenges of low and middle income countries in mind. But we know that in order for those programs to be successful, they require very strong healthcare systems, as well as healthcare financing, which is something we have not touched upon yet. So here's an example, a very kind of schematic example of the 5 levels. Cardiac surgery actually appears in level 4 and 5 only, but in levels 1 to 3, we believe that there's just diagnostic and referral services to levels 2 and 4 and 5. I'm sorry. And the several aspects that we believe were important to make those recommendations on. First was based on age of the patients treated. Then next was general anesthesia, the human resources necessary, the required skills necessary of the people employed there, the infrastructure availability, equipment and supplies, and quality and safety systems. If you're interested, please contact me and I'll share with you the guidelines. I'm not going to take any more time. Some of the challenges, we largely had broad support, but some of the professional societies felt that they should have been developing those themselves. And so, however, I wouldn't say anyone has challenged the guidelines. And the next steps, we want to actually start working on policy recommendations, which would be focusing on regionalization, population-based, as well as financing. And with that, I thank you, and I'll stop here.
Hello, colleagues. My name is Josephine Chekowitz. I'm a pediatric otolaryngologist based at UCSF. I practice primarily at our Biennial Children's Hospital, Oakland location. Thank you so much for this opportunity to speak with you at the Global International Children's Surgery webinar. For this very short talk, I'll be speaking some on a few areas of inequity between LMICs and HICs when it comes to otolaryngology care, and then giving you kind of the 10,000 foot view of the landscape of ongoing collaborative work in our specialty. So in terms of areas of inequity, hearing loss, 5% of the world's population has disabling hearing loss, and unfortunately 80% of those folks live in low and middle income countries. And here you can see, again, this is a problem disproportionately borne by the global South. There's poor access to hearing rehabilitation and hearing aids. Less than 20% of folks in low-income countries have access. And a lot of these causes are preventable. Perinatal infections like CMV, meningitis, noise exposure, and ototoxic medication use are all more prevalent in resource-constrained settings. I have a particular interest as a pediatric otolaryngologist in congenital hearing loss. And you know, of the 500,000 infants born annually with disabling hearing loss, 90% of those are in low and middle income countries. Also, programs for early detection and intervention are crucial for facilitating normal speech and language development. And in many places, there's very little access to either screening or interventions. Another entity in otolaryngology, chronic suppurative otitis media, which does lead to hearing loss, but this is a surgical disease. Much higher prevalence in LMICs, and access to surgical care is extremely limited in LMICs. And again, this leads to hearing loss, infection, and intracranial complications. Head and neck cancer, 2/3 of the global burden is in LMICs, resulting from increased risk factors like smoking, wood fuel use, and HPV prevalence. And also disparities in access to HPV vaccination. And my colleague Shazia Pierre will be speaking tomorrow on research on recurrent respiratory papillomatosis and disparities in particular in children. And then lack of early diagnosis and care in these diseases. Other areas of sort of overlap between otolaryngology and global health: cleft lip and palate, facial trauma, management of thyroid disease, and also general care for oral disorders. In terms of global efforts, in 2018, the Lancet launched a commission on hearing loss, focusing on the areas of prevention technology policy and protecting existing hearing. The WHO in 2017 launched the Hearing Loss Task Force, which is focused on improving access to assistive technologies, prevention of deafness, and prevention of hearing loss. And the WHO facilitates World Hearing Day, which is coming up on March 3rd. This year's theme is To Hear for Life, Listen with Care, and it's all about protection from acoustic trauma. In pediatric otolaryngology, specifically throughout the pandemic, the Global OHS Initiative was founded by some otolaryngologists at Harvard who collaborate with folks all around the world. And the goal has been to collaborate electronically, virtually, to expand the conversation and connect the community, to integrate into the global surgery movement, and then to work on research and inform policy. And again, equitable representation of LMICs and HICs has been part of this from the start. And so there's a lot of ongoing work on research, lit reviews, equity, and again, we have monthly meetings, and for more information, you can check that website. Here's some of the publications, just a couple other service organizations that collaborate. And with that, I will thank you for your time and take any questions.
Ladies and gentlemen, dear congresses, thanks to give me the opportunity to present this conference on bladder atrophy management in Africa. For this conference, we will use this plan. Bladder dystrophy and epispadias are malformation characterized by anatomical aspect. Epispadias, the urethral is partially or totally open to the dorsal side of the penis. In bladder dystrophy, the bladder is open on the anterior-lower abdominal wall. In cloacal dystrophy, the bladder and the ileocecal intestinal junction are open on the anterior-inferior abdominal wall. This is some cases of epispadias, classic bladder dystrophy, and cloacal dystrophy. Bladder dystrophy is the most complex malformation in pediatric urology, fatal and devastating for patients and parents until 1970. Focus are done now on optimization of the care. It's a great challenge in developing countries. The controversies are about age at surgery, in neonate or later. Several strategies or surgical techniques are described. Modern stage repair dystrophy, complete pulmonary repair of bladder dystrophy, or Kelly operation, or radical soft tissue mobilization repair. For all these controversies, the aim of all these strategies is the same. Close the bladder to pass urine and have acceptable social continence, reconstruction of the external genitalia to achieve a satisfactory aesthetic appearance and to allow normal sexual function. Some surgeons do ureterosigmoidostomy derivation. What is the current situation in Africa? We sent a survey about bladder dystrophy management to all pediatric surgeons and all pediatric urologists by email and by WhatsApp group. The survey was filled by 25 centers. This is the survey. The result: most surgeons work in level 3 hospitals. The annual mean incidence was 3.5 cases. Only 3 centers did antenatal diagnosis. The surgical period was in neonates in the most of cases and in infants. The reason of surgery delay was the size of the bladder plate. In 5 cases. Most surgeons did staged surgery in 3 steps, with osteotomy sometimes. The age at the initial bladder neck repair was about 5 years in most cases. Bladder augmentation was done in 15 centers with the use of helium in the most of the centers. Intermittent catheterization was done by Mitrofanov or by urethra, sometimes in 10 centers. Urinary derivation was never done in the most of centers. Only 1 center did that. The complications are observed in 15 centers. It was gallbladder dehiscence or urinary tract infection in 50 centers. Most centers do the evaluation of the continence, and some patients were continent in 10 centers. Kidney function was evaluated always. and always by biology, and sometimes by DMSR only in a few centers, in 2 centers. There are no deaths in 10 centers, and in 6 centers, the mortality is ranged from 2% to 20%. In summary, the majority of hospitals are level 3. There is a lack of antenatal diagnosis. Child was received at any age. Surgeon performed 3-stage reconstruction with pelvis osteotomy. Sometimes small bladder plate size is the primary reason for delay management. Reconstruction of the bladder neck is mainly done around 5 years of age, with some augmentation of the bladder. Complications were observed where bladder wall dehiscence and urinary tract infection. Continence is sometimes acquired for most. Renal function is normal, and generally there was no mortality. Our experience at teaching hospital, we see in this diapositive the step of bladder closure. Here we have a case of bladder closure. Here is a cystography after bladder closure. Here is a case of bladder closure with a child who has urination, with a good flow of the urine. In conclusion, we need for bladder management, bladder dystrophy management, specialized centers, multidisciplinary team with psychologists. Reconstructive surgery must be adapted to each patient. Success of the first procedure is very important for continence. The goal to make all patients socially continent can be achieved in Africa too. Thank you for your attention.
Good afternoon, friends and colleagues. Good morning, wherever you are joining us from. My name is Lawan Ayedun Olugomi, representing GICS Nursing Working Group. Thank you for joining us. And in the next few minutes, I'm going to be sharing with you updates from Nursing Working Group. Thank you once again, friends and colleagues. This is actually interesting to say, and I'm excited about it, to say how we started GICS Nursing Working Group. It all started in Johannesburg, 2020. Amazing year with all the COVID later on, but we had a new beginning as nursing, being part of GICS. In Johannesburg, we have about more than 10 countries represented, from the nursing community. And some of us, like you're seeing in these pictures, we agree that yes, to provide quality pediatric surgical care, we need to be part of this global initiative. And that is why we came together, we agree. And thank God, thank the leadership of GICS, we now have a very strong, resilient nursing working group for GICS. Thank you. On this slide, I just want to use this opportunity to quickly share with you what we've done so far, starting from 2020 in Johannesburg. So after the consensus was built and we agreed that yes, we want to be part of GICS, what we did was also to do what we call membership drive. We all also record the COVID destruction, but that do not really things stop was because we are just too focused. So we had a couple of virtual meeting, workshop, thanks to the GICS leadership that gave us this platform. And we're able to start off monthly meetings by colleagues around the world, particularly colleagues from about 8 countries that I've mentioned earlier. And of course, we are also be able to provide national and subnational nursing care, even at that a challenging period of COVID. And I want to say thank you to all colleagues who really sacrificed their lives, their skills, their time in saving life during that pandemic. In 2021, we also remained focused. We're able to develop a concept notes or a concept paper alongside with a desk review of pediatric wound care in about 7 countries, because wound care for pediatric, especially the pediatric surgical wound care, is also a major challenge for us in LMICs, looking at the reagent, the skill that is required to ensure that wounds, surgical wounds, is or they are kept clean and not infected. So we had that, and by tomorrow you will have the details of where we are around the wound surgical care research that we are doing. Of course, we are able to also hold and sustain our monthly meeting in 2021. We also advocate for optimal resources for children's surgery in low resource setting, like in LMICs, where we have poor health insurance scheme. You know, like for instance, in Nigeria, we have about just 5% NHIS coverage. In country like Tanzania, is about 3%. So, which means that lots of children who desire or who deserve to have surgical intervention might not have it just because of poverty and there's no insurance coverage. And after that, we are also be able to do a membership drive, which we advocate to nurses to join us through GICS platform. And I can say with all excitement that yes, our numbers increases day after day. And at the level of GICS leadership, at the level of board, we are also happy that we're able to contribute and giving us the platform to be one of the board member. And I want to say kudos to GICS leadership. Thank you, especially now under the leadership of Professor Ame. So still moving on in my presentation and coming to conclusion, I just want to say with all humility that reaching the unreached with universal access to emergency and essential pediatric surgical care depend largely on our ability to help each other succeed in the spirit of leaving no one behind. Trust me that this saying is still true and relevant. When we say alone, we can do so little. Together, we can do so much. On that note, I want to say that in 2022, we want to work with you more. We can't do it alone. And we'll still continue, and we want you to join us in our membership drives. All our colleagues, the surgeon, the physician, the gynecologist in this conference, we want you to please allow us to work with you, connect us, and link us up with your nurses. We want them to join GICS Nursing Working Group. We also want to ensure that we are able to conduct our research on pediatric wound care. So look forward to our mail, our survey, so that you can also help us to disseminate and also attend it as well. Of course, our monthly meeting remains the same. Every month, the last Saturday of the month, we meet as GICS Nursing Working Group. And we have interest, and we plan to organize workshop training on neurotube defects and on facial clefts. So please feel free to connect with us if these are also your area of interest. We want to work with you collaboratively. We also want to engage more partners. Once you know you are working on pediatric surgical care, we need to work with you. We want to work with you. We want to know you. And capacity building, training, research capacity. As we all know that research in the domain of nursing is not really pronounced, and this is one of our weak areas. You and you can help us to strengthen this aspect. And one thing that is also an interest area for us is the issue of NSO, National Surgical Obstetric Anesthesia Plan. And I want to say with all humility that there can be no successful surgery without quality nursing care. And that is why I really want to advocate that please, countries, consider integrating nursing in your NSO as you plan to implement, as you are in your process of planning as well. So thank you for listening. I just want to say on the final note that Global Nursing Leadership Institute by ICN is having the annual program, and this is an opportunity for nurses all over the world to apply this very, very educative program, and the deadline for submission of the application is March 31st. So please just take an opportunity to apply for that. So finally, thank you so much for listening, friends and colleagues all over the world. Looking forward to working with you in 2022 and beyond. God bless you.
Hi, my name is Guy Jensen, and I've recently had the opportunity to work with the GICS trainees, sometimes called the Core Operations and Logistics, or CALL group. Thank you so much for the opportunity to talk today. I want to thank all the trainees from the group who are doing so much to keep this meeting running today. Just because you can't see people running around like some of you may have seen me do at meetings in the past, doesn't mean there's not a lot going on. Behind the scenes, there's a lot of people working really hard to put on this webinar today. Trainees have always played a really important role in GICS, and I want to talk a little today about things trainees have worked on and why I think getting involved in GICS. Trainees working with GICS have helped organize meetings and webinars, and this has always been one of the most important jobs. Numerous local trainees in Vellore, DC, London, and Johannesburg have really rolled out the welcome mat for the organization in their home country. Trainees have helped to organize working groups and keep these groups that are a big part of what GICS does moving between the meetings as well. Trainees have worked on the Optimal Resources for Children's Surgery document, as well as numerous publications that help us get out GICS message and be part of the worldwide conversation around global surgery. And so while these things fit really nicely on a CV, there's another part of being involved that I think is worth mentioning and has been a really important part of my learning as a trainee involved with the organization. While it may not seem important for providers to learn how a nonprofit organization works or how to run a meeting or webinar, the reality is that organizations like GICS are a big part of how we all work toward our shared goal of safe surgery for every child everywhere. So whether it's working groups, writing papers, working on NSOAPs, you can gain skills and knowledge that can help make you successful no matter where you're looking to make an impact. The other big part of this is connections. This is a huge part of why you should be involved in GICS. GICS is a worldwide community encompassing people of different specialties and experiences around the world. And for trainees, there's a lot of people in whose footsteps you can follow. And by getting involved, we can help you make those connections. The trainee group can play an important role as a matchmaker, if you will. Whether you're looking for a coach, a mentor, or just looking to make connections with people who have a similar interest, then GICS has a role, the GICS trainee group has a role to play in helping you do that. And the people and the connections you make are the best part. So I think the trainee group is a great way to get started at GICS, and it's for trainees of every level. And so while a lot of the activity is focused around the meetings, I do see the role of this group continuing to grow, hopefully serving as a good place for trainees to network and gain access to not only people, but organizations and ideas. You're going to hear about a lot of great ideas and projects today. And whether you're a trainee who wants to work on a project on financial protections or a checklist for safe anesthesia, there's something for you in GICS, and the GICS trainee group can help you get involved in that. So I want to encourage trainees everywhere to reach out and get involved. Email us at gicssurgery@gmail.com. Tell us who you are, what you're interested in, and we'll be happy to get you involved in the organization. And for all the trainees who've been involved over the years and are involved today, thanks so much for all you're doing. Thanks for the opportunity to speak today as well.
All right, Hafiz, go ahead and lead the discussion if you don't mind.
This session has been quite an interesting one, and I thank all the working groups for such a wonderful presentation. We have a few questions to the pediatric surgery working group. How much subspecialty training should trainees have so that they can stabilize patients before referral to specialized centers?
Thank you very much, Chizom. I'm not sure I understand this question well. How much subspecialty training should trainees have so that they can stabilize patients before referral to specialized centers? I don't know the answer to the question. Maybe some other people can help me. But the issue is, if you are a subspecialty trainee in pediatric surgery, then you should be able to stabilize the patient. And I suspect that if you are already, if you are in a training program, then probably your center may even be the referral center. So maybe if you can ask the question in a way that's quite clear, maybe I'll be able to address what the person has in mind. I don't seem to get it.
Well, the person who asked the question went ahead to say that there is so much to learn during training that they can't become experts in everything in just 2 years of fellowship. How do you also learn how to be a pediatric cardiac surgeon, orthopedic surgeon, neurosurgeon, etc.? I don't know if that helps.
Okay. So, well, I think from the experience, from my own experience in Nigeria and Lagos particularly, usually when you have a senior registrar coming to our unit, many a times they understudy the more senior residents in the unit, and they learn the ropes. And by 6 months of training of doing that, they can do all the basic resuscitation that you need from neonatal period to older children. So within 6 months, a trainee should be able to stabilize patients, prepare for surgery, and be ready to monitor the patient. Learning the art and skills of surgery is a totally different thing. And I think this person asking the question should not be overwhelmed by all the subspecialty, neurosurgery and all that. You rotate through all that. And by the time you have decided where you want to be, then you stay there and you pick the skills of that particular subspecialty. But to answer the question, I think 6 months is about the average for somebody who is coming into specialty training to be able to understand the resuscitative efforts, for children, and then will then from there move on to acquiring the skills of surgery. I don't know if that helps. Thank you, Chisom.
Thank you. The second question goes to the urology group. Are there standardized bowel management programs through GICS? The second one, did you look at short and long-term quality of life in cloacal estrophy? Sorry, I'll take the question again for the urology working group. Are there standardized bowel management programs through GICS? Second, did you look at short and long-term quality of life in cloacal estrophy? Okay, so I'll just move on to the nursing group. Is there a flyer or link with information to share to potentially interested nurses? Secondly, who is the best person to connect our nurses to?
Hello, thank you very much for that question. I just shared my details on the chat box, so you can reach out to me. However, you could also reach out and using the GICS email, and definitely that information will get to me. I happen to be the coordinator for the nursing working group, so I'll be so glad to have more nurses working together. Together we can do so much. Thank you, and over, Chisom.
Thank you. For anesthesia, there was a question about why was there no presentation from the anesthesia working group? Are there training opportunities for pediatric anesthesia?
I hope the breakout rooms will provide more opportunities for more in-depth discussion of all subspecialties.
I'm happy to answer that too on behalf of anesthesia if you'd like. This is Faye Evans, and I think Zippy is on as well. We apologize for that. There is stuff going on with anesthesia. One of the projects we wanted to discuss, we weren't really at liberty to discuss at this point. However, we did, I believe, show a PowerPoint of some of the activities we've been involved with. But if you want to learn more about what's going on, we would just encourage you to come to our breakout group a little later.
Thank you so much. Right, if there is no other questions, we can adjourn this session.
Thank you so much to both you and to Chisom. All right, we'll move on to the next session. Ruth, why don't you go ahead and Daruk will do his introduction.
Hi, Daruk Osgood is a pediatric surgeon at the University of California, San Francisco, and I'm just going to be introducing the next session, which is on global vaccine equity. We have two speakers, George Rutherford from University of California, San Francisco, who's a pediatrician and infectious disease epidemiologist and leads our global health programs. I'm not sure that Dr. Roy from India will be able to join us. He was going to join us live, so we may play George's video and then have a short discussion about global vaccine equity.
Good morning. I'm Dr. George Rutherford. I'm a professor of epidemiology and pediatrics at the University of California, San Francisco, and the acting executive director of the Institute for Global Health Sciences. Today, I'm going to be talking about vaccine equity. in the age of COVID-19. Vaccine equity refers to the equitable distribution of vaccines across nations and among groups within nations. Child mortality, I think, is a good place to start, which has decreased by almost 70% from 12.5 million deaths in 1990, at the start of the Millennium Development Goal Project, to 5.2 million in 2019. The reason these have decreased is a large number of them are preventable. And among older children, once you're out of the neonatal period, pneumonia and diarrhea are the single largest causes of death. And as you can see in this map, these are not evenly distributed across the world. And if you can see, the proportion of newborns who die before their 5th birthday are most concentrated here in Central, West, and East Africa, with countries like Nigeria, the Central African Republic, and Chad having the worst parameters. Child death has fallen in all groups: children 1 to 4, children in their between 1 month and 12 months of age, children between 1 week and 4 weeks of age, and children under 1 week of age. All of these have come down, less so among neonates than among infants and children. So what do children die from? As I said, the bulk of deaths are from pneumonia and diarrhea, but there are also other major killers. Malaria, tetanus remains a major issue, measles, pertussis, and meningitis, and this is all meningococcal meningitis. So you can see that many of these are vaccine preventable. Interestingly, of 80% of under 5 deaths in 2012, the year for which we have pretty good data, were in 25 countries, and 50% of those deaths were in 5 countries. So it's a very targeted kinds of series of interventions. If we were to eliminate, if we were to decrease inequities in our prevention programs, and here's one with regional equity, we could avert 4.4 million deaths. And if we had global equity, basically bringing everybody up to the same level, to a basic level, we could avert 5.1 million deaths. As I said, a lot of these diseases are vaccine preventable. The proportion of preventable deaths, this is not just in children, this is among everyone. So Hep B, measles, Haemophilus, pertussis, neonatal tetanus, tetanus in general, yellow fever, diphtheria, and polio. This does not have COVID-19 on it, which, as you know, would be way up here towards the top. Now, COVID-19 has been a big problem. Global coverage for complete pediatric vaccination has fallen between 2019 and 2020. And it was estimated that 23 million children under the age of 1 year did not receive basic vaccines, the highest number since 2009. Just to put this into perspective, there are 140 million births, so 23 out of 140 million. In 2020, the number of completely unvaccinated children, never received a single vaccine, increased by 3.4 million. So that's about a seventh of this number here. And 1.6 million girls were not fully protected against HPV in 2020 compared to the previous year, which will come back as cervical cancer mortality at some point in time. Now, admittedly, vaccines are not the only problem that COVID has caused in children. We have worsening mental and emotional health, a widening of existing educational gaps, decreased physical activity and increased BMI, decreased healthcare utilization in general, decreased routine immunizations, which is the subject today, increase in adverse childhood experiences. This is largely problems in the families that lead to child abuse and long-term mental and social underperformance. And then don't forget loss of caregivers. So the Gates Foundation, in its annual Goalkeepers report, summed all this up. And what they said was there's been a major backsliding in percentage of children around the world getting essential vaccination. Excuse me. Food insecurity is on the rise, and there's been a sharp increase in the number of people living in extreme poverty. In the first 6 months of the pandemic, we saw the number of people living in extreme poverty around the globe rise by 7% after declining year after year for the past 2 decades. And in the Stark report, in the report Stark Appraisal, in other words, we've been sent back 25 years in about 25 weeks. So how do we fix this? And there are a lot of data about how far behind we are in pediatric vaccinations, but we're way, way, way behind. We need to restore services so countries can safely deliver routine immunization services during the COVID-19 pandemic, while all the time adhering to hygiene, needle safety, and physical distancing recommendations and providing PPE to health workers. We need to help health workers communicate actively with caregivers to explain how services have been reconfigured to ensure safety, that is so that they'll come in. We need to rectify coverage and immunity gaps. And while we're at this, we need to address disinformation around COVID-19 vaccine. It's not only in the United States where this is happening, it's happening throughout the world. We need to expand routine services to reach missed communities where some of the most vulnerable children live. Thank you very much. And I'm delighted we've been able to discuss this morning, and I look forward to hearing your questions.
George, thanks for joining us, and thanks for that great talk, which I think is a great interest to everyone on the webinar. Could you also say a little bit more about where we are with COVID vaccine inequity between high and low income countries, and what we've learned and kind of what we need to do? You're muted, I think.
Thanks, Daruk. Sure, it's a pleasure to be here with everyone this morning, wherever you are. It's morning here. So the developed countries are here, and the low-income countries don't appear at all. Okay, so charitably, there's 3% vaccination coverage in low-income countries, and it's just glaring. They're in massive inequities. Now, having said that, there's a lot of vaccination hesitancy all over the world. We've had recent experiences in South Africa and Kenya with vaccine hesitancy. All of Eastern Europe is hesitant. They're completely disinterested in this. Not all, but it's not like it is here in the United States or even in Canada. And so I think that there are glaring deficiencies between high income and low and middle income countries, which can only really be reversed with provision of vaccination. Now, the UN has set up an agency called COVAX, which is sort of spin-off on the Global Alliance on Vaccines and Immunizations, Gavi, which is trying to raise donations from donor countries and others like pharmaceutical companies to provide enough vaccine for 20% of low-income countries. It's also creating a purchasing pool so people can buy at reduced costs, just like in the TB. There's a TB central purchasing mechanism as well. Now, what does 20% buy you? 20% coverage buys you healthcare workers and buys you people over 65 or 70. And that's really the only thing that I think is a reasonable target at this point in time. Given the youth bulge in Africa, there's going to be a lot of transmission. It probably has been a lot of transmission already. We saw estimates from a country, and I'm sorry, I can't remember which one it was, but it was, a Southeast Asian country that said maybe 70% of people had antibody already, which is astounding. So I think it's a real open question about how best to proceed. I like the idea of starting with healthcare workers and the elderly, because they're the ones who are at most at risk for A, acquiring it, and B, having bad outcomes from it. So I think that makes sense to me as a place to start. But the pediatric vaccines are going to lag way, 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 way behind.
And George, also just to follow up, in terms of local production in, say, Africa and other low-income countries, have there been any strides forward?
Well, India makes most of the vaccine right now, makes most of the AstraZeneca vaccine. It has a different trade name. I can't remember what it is, but so India is already doing this. Now, I saw an article yesterday that said Pfizer was creating mobile production facilities that could be distributed in low and middle income countries. So yeah, maybe, but there are really only a handful of countries that have this capacity for vaccinations or for vaccine manufacturing. And it's not necessarily, it's a lot easier to get it, to have it delivered to you than to set up a plant with all the quality controls and all the pieces that need to be in place. Thailand, India obviously is huge. South Africa, Brazil are the ones that have the biggest manufacturing capacity. And it would be nice to have a few more on that list as well. But for now, there is this little small movement towards mobile production facilities, but I'd like to see it. I'd like to see it expanded to. I know Nigeria has some, Kenya has some, but it needs to be pushed out a little bit, even a little farther.
So I'm just seeing some comments in the chat that 6 African countries were empowered to begin local production of COVID vaccine just a few days ago.
Good, good.
We're hoping for that.
Is that for the AstraZeneca vaccine?
I'm not sure it's from.
So there's a real interesting thing going on. And I should have mentioned this. Baylor College of Medicine with Peter Hotez as the PI there has developed a subunit vaccine, kind of like hepatitis B vaccine. You're just injecting the spike protein and as released. And so it's, it works okay, 80%, 82% something vaccine efficacy probably, as opposed to 98% with the mRNA vaccines. But it's 1980s, 1990s technology, and you can do it wherever you have a brewing industry. You can cook this stuff up. And it's a lot easier to get to fill and finish, and the QI is a lot more straightforward. There are many fewer side effects, even though the side effect profile is very low with the mRNA vaccines. There are even fewer still with these subunit vaccines. And so I think that's another kind of approach, and that might be what the 6 countries have gone for. There's a new vaccine that's going to come down the pike here in the US pretty soon called Novavax, which is also a subunit vaccine. So instead of injecting messenger RNA that tells the cell to make spike protein, or an adenovirus that inserts, gets into the host cell's DNA to tell the cell to make spike protein. This just injects spike protein right into the bloodstream and elicits an immune reaction that way. I can't imagine it's going to be very long lived, but it's, it gets us to start.
Thanks, George. There's some more comments in the chat. I'm just going to kind of maybe be a little provocative here and just say, I think for a lot of the people on the webinar and all of us, this has been probably the greatest global health failure that I can recall. Is the availability of vaccines in low-income countries and the distribution. And I think hoarding in high-income countries and a lack of global cooperation has been a major issue. And so I think we all feel a lot of anger. So,
get in line.
And so we're supposed to be coming together and solving these problems, and yet we failed. And so I wonder kind of how you look at that. What does it say about global health? What does it say about what we need to do now? And I feel free, anyone that has comments in the chat, please feel free to add them. But
yeah, well, you're right. It means the colossal failure of the global health security infrastructure that was put into place in the George W. Bush administration by the U.S. and by our European and sort of Pacific Rim allies. And it's because we, the U.S., backed away from this and treated it as a kind of foreign invasion, which was probably well, first of all, it didn't work at all. So it was a failure from the start, but it's not the way to approach these problems. And I think we're going to see a newer commitment to global health security going forward. There's going to be a much more central role for WHO, which is not widely appreciated in many high-income country capitals. That is, it's treated with massive distrust, and it's just not a there's a long way to go to get this repaired, but hopefully this will be the wake-up call, just as SARS was the wake-up call for the international health regulations in 2000 that finally got finalized in 2005. But it's a long way to go, and what do we need? You need money. A lot of money. You need people to be trained. You need cooperation. You need sovereign governments willing to say, okay, international community, have at it. You can come in and you can put up a cordon sanitaire around this city. You can monitor this, you can help us control it. So it's going to be wild. And if we were in my office at UC San Francisco, I have a movie poster from this really bad Dustin Hoffman movie called Outbreak, where there was a filovirus outbreak. This is all pretend, of course. There was a filovirus outbreak from a imported monkey in a little town in Northern California, where the army swept in and put up a cordon sanitaire and was going to, blast it back to the Stone Age to control the virus. You don't want so that's just like crazy between state and federal stuff. You can imagine if there were international partners involved, what it would look like. It's a long road to go to get this fixed. But you're absolutely right, Daruk. It's a colossal failure.
Maybe one last question. I think there's a lot of comments in the chat that, in the high income countries, often vaccine hesitancy is pointed to as the problem, but it's really actually availability because most people want it.
In low income countries?
Yeah. I think that's any of the comments from a lot of our LMIC colleagues. I think the other question is, it's global cooperation, but what about the pharmaceutical companies, the manufacturers, and what's their responsibility here and where have they failed, and what actions would it take to hold them accountable for a lack of global viability?
I don't know that it's their fault or their failure. They do what they're told by their payers, who is the U.S. government in this case, or the British government. They do as they're instructed. I think that the only end run in this whole thing is this subcomponent vaccine that Baylor has put together that kind of end runs the whole deal. But they're perfectly happy to sell vaccines to COVAX if the orders come in, and they can gear their production lines up and down. There's a lot of flexibility with mRNA vaccines. So I don't see them as particularly holding the bag on this, although, maybe a few of them haven't been the world's best players, but it's the governments that buy and direct their production that I think we need to be looking at even more.
So what would be, kind of from your perch, advice for a group like ours? Most of us are clinicians and public health folks focused on child health, and particularly around surgery,
right,
to actually kind of make a statement about this or move the needle in some way, given our kind of our platform as kind of frontline providers around the world taking care of
I think Daruk, it's important to know what you're asking for. Are you asking for healthcare worker vaccination, which is where I would start if I were you? Are you asking for under 5 vaccinations, which don't exist in any country at all? And is that the most necessary thing? If you're looking at where the mortality occurs, it occurs and then heavily exposed healthcare workers, at least initially. And again, would be my, assuming there's not a universal supply, and assuming that the under 5 vaccines eventually get approved, which we would expect sort of April, May here in the U.S. I think it's going to, I think you have to prioritize how you want this rolled out. I think WHO is as good a conduit as any, maybe the World Medical Association, or other conduits to get this done. But I think lobbying the big developed world governments rather than the vaccine manufacturers is the way to push this agenda. We actually do have, as you know, Daruk, we have a British charity that we cooperate that's called Get One, Give One Worldwide. Which is the idea is that you who get an mRNA booster when somebody in South Africa gets nothing, you can give $7. It's a mechanism for giving the cost of an mRNA vaccine to COVAX, and so it's meant to be a kind of on the ground, grassroots philanthropic effort to provide greater vaccine distribution. It's it's tiny stuff, but it's a way to start. And I kind of like the idea of, whenever people are asking me, I feel really guilty about getting a a booster dose, which I hear very seldom, by the way. I say, we have this whole thing set up, here's the website, go for it. And you can get all your friends to give to it too. That would be great. But that's, that's drop in the bucket stuff. This really has to be fixed at the level of governments.
Thanks for that. I'm seeing a lot of comments in the chat. For those on the webinar who have, perhaps we can put together something from the perspective of GICS to speak to this. We have personal experience moving the needle locally on vaccine availability, and any advocacy strategies that have been successful, please share them either in the chat or with our group. But I think we are going to move to a break. Any other comments? Marilyn, is it, or Emmanuel?
Yeah, thank you very much, Doruk, and thank you, George, for the excellent discussion. So we will take a short break to take us to the top of the hour before we move on. So this do take time to stretch and relax a bit. Thank you.
Thank you, George.
You bet. Take care, guys. Good luck.
Right, so welcome back, everyone. We are going to be moving to the next session. The next session will be the mitigating the impact of COVID-19 on children's surgery. And Sabina and her trainee moderator will be handling that session. So Sabina, over to you.
Thank you, Dr. Ame. My name is Sabina Siddiqui. I'm a pediatric surgeon at Arkansas Children's Hospital, and I'll be moderating the session on COVID-19 with our Nigerian colleague, Dr. Majid Kontunmi. COVID-19 has been a prevailing theme at this children's surgery meeting. And while COVID-19 has provided us with unique challenges that we just discussed, it's also provided unique opportunities for our innovative and passionate membership who has continued to provide excellent care to children all over the globe despite this virus. So this session will share some unique perspectives as to the impact the virus has had on the practice of children's surgery around the globe. That's your cue, Ruth. You can play the first one. So I'm presenting the GICS membership survey on the impact of COVID-19 on pediatric surgical care. So the GICS, which had organized 2 action planning forums to study the impact and to plan remedial measures for the fallout of the pandemic on children's surgical care, went on to do a GICS survey of its membership to assess the ground situation in different countries worldwide and to plan strategies to jointly address the late effects of the pandemic. So this methodology for this was formulated by following the Delphi method. An LMIC researcher formulated the survey questions. These were initially reviewed and modified by a panel of 5 GICS leaders, followed by a number of larger panel of active GICS leaders from different geographical locations and specialities. This was followed by cognitive testing, which resulted in modifying and simplifying the questionnaire. And then an IRB approval was made, and the survey was circulated to both LMIC and HIC practitioners of the GICS. So a lot of information was elicited in the survey, which used 62 questions. So the survey was distributed through email blast. It was done in between October and November 2020. The map shows that most of the providers were from Africa and Asia, and expatriating from the other countries. The specialties were mainly pediatric general surgery, plastic surgery and orthopedic surgeons also forming a significant number. The hospital coverage was mainly regional and national level hospitals, and majority of respondents, or 82% almost, were from LMIC. So the countries were mostly in stage 3, 4 and 5 of the disease, and though 88% had some form of lockdown sometime, at the time of the survey only 50% had lockdown, 24% partial, 6% complete, and 50% had no lockdown. The decision body was mainly institution, whereas individuals did make the decision about doing surgery or not in about 1/3 of the cases. 50% had already resumed full elective surgeries, and 92.5% had guidelines for COVID care. Most of these were national and institutional guidelines helped by the WHO and other guidelines. So patient screening was done by COVID testing, but mostly in majority of the time it was done by the contact history, history of travel, symptoms and temperature. Workplace safety measures were used by more than 60% of the times, with eye protection, gloves, N95 or equivalent surgical mask and hand hygiene being followed. The provision for COVID testing was mainly available for symptomatic patients only, whereas asymptomatic contacts and others had less than 20% access to this. Quarantine facilities, COVID testing, access to PPE, isolation facilities, spacious consultation rooms, screening was available in more than 60% of the, for at least between 60 to 80% of the hospital. PPE of level 3 were available only in 31 out of the 84 respondents, with no access being available for 2 out of 84 respondents. And the need for safety improvement, however, was felt by more than between 40 to 60% in either COVID testing, universal PPE, or designated high-risk area. Improvement in safety of healthcare workers was desired, and the need felt was for PPE and N95 masks, as well as shift system and designated dining and changing areas. The working hours were mainly for most of the patients, for the most of the care providers, it was less than 12 hours, with few less than 7.4% having to do more than 12 hours. Impact on clinical care was felt, both the disruption in the OPD, decrease in numbers and increase in remote consultation, decrease in caseload, both outpatient and the elective surgery was felt, with more than 6 months increase felt by, with more than 6 months delay in surgery being noted by 18, and more than between 3 to 6 month delay in surgery noted by 44% of the respondents. Adverse effect on morbidity anecdotally was noted by 35 out of 86 respondents, and they felt that the cost of treatment has gone up because of the PPE expenses and COVID testing. There was a delay in seeking medical help by the patient, and it was mainly because of the fear of infection and difficulty in travel, in addition to limited resources,
unavailability of the medical workforce or the hospitals, or because of the quarantine rules enforced either in the area of the hospital or in the place where the patients lived. So there was an indirect effect of the pandemic on pediatric surgical care and alteration of health system and reallocation of global resources further hampered this children's surgical care. So challenges faced by children's surgical providers in GICS were cancellation of elective surgery, delayed access to care, inadequate availability of resources, diversion of resources towards COVID care, and interruption of surgical training programs. So the restriction on surgical procedure depending on the stage of the pandemic and the diversion of resources towards COVID care had a negative impact on the surgical care. So to aid resumption of services, surgical society's criteria for triage, prioritization, and operative protocol has been suggested, and most institutions have already used this criteria as a foundation. So targeted screening tests detected infection and helped to manage resources, and the shortage of PPE was mainly because of the reduced supply and increased demand. These were more severe in LMIC. Workplace safe practices have been set up to control infection rates among healthcare providers, and this requires screening centers, segregation areas, and areas for donning and doffing PPE. There's no uniform, these are however not uniform amongst institutions, and it was felt that they were not always adequate. So it is suggested that the backlog of outpatient and surgical care is multifactorial, and it is both because of fear among the doctors as well among the patients of acquiring infection. In addition to that, lack of transport, lack of finances, and lack of support facilities, including transport around the hospitals. Delay in surgery is also because of financial constraints and increased rates of care, because it has become more expensive to get the surgery done, and also difficulty in travel. So one of the breakthroughs that was noticed was the widespread use of the telephone and video consultation, and it is suggested by the GICS membership that to unburden the surgical practice, more surgical camps, shifting system for surgical care providers, improving funding both for the patients and for the hospital, training to improve the manpower, and additional operating room time may be desirable. Thank you.
Good day. Thank you very much for your time. I would like to present about the COVID-19 impact in Indonesia. Before that, I would like to introduce myself. My name is Ricardo Milano. I'm a pediatric surgeon from Indonesia. Well, the committee gave me time to talk about the COVID-19 impact in Indonesia. So I tried to divide the impact of COVID-19 in Indonesia into 3 waves. The first wave at the early of 2020, in Indonesia, we have the pandemic start from March 2020. And at the time, all the surgeries, especially the pediatric surgeries, are suspended. Only the emergency cases only. So at the time, we don't have any consensus. So we took some consensus, including from American College of Surgeons, how to start the surgery or how to make the surgery more safety. And the second wave is start from the early of 2021. The surgeries in pediatric surgery cases can schedule, but with supporting examinations, including chest and oropharyngeal or nasopharyngeal PCR swab. The types of surgery and the degree of emergency can be decided by the Indonesian Pediatric Surgeon Society. And the third wave is start now. As we know that COVID right now, mostly caused by Omicron, we can schedule pediatric surgeries, but still with supporting examination, including chest radiograph and PCR swab. But unfortunately, the number of surgery decreasing because nowadays there's an increasing amount of infected patients, and the type of surgery and the degree of emergencies can't be decided by Indonesian Pediatric Surgeon Society. So, in several central hospitals, most of this hospital has converted into a COVID-19 referral hospitals, and the number of beds in general pediatric wards decreases drastically, and referral patients unable to be received in the hospitals. So it's forcing them to choose hospitals that have beds but not pediatric surgeons. So what GICS might do to help? We have to admit that there's a restriction of symposium and workshop because of this pandemic. We can't invite the guest lecturers, or we can't go outside to have our broaden our knowledge. So we greatly hope that online training can be done by some well-known experts from abroad for developing countries like Indonesia. So we hope that the training will involve not only lectures, but also virtual workshops in which the instructors can show surgical procedures and skills to participants online. Thank you very much.
Hello there, my name is Soham, and I'm here today to talk about the Global Children's Non-Communicable Diseases Collaborative. This is an international collaborative of researchers and clinicians who are focused on improving the health of children with non-communicable diseases, such as cancer. This study specifically focuses on how the COVID-19 pandemic has impacted children with cancer in low, middle, and high-income countries. Now, cancer is an issue worldwide. It is currently one of the leading causes of death in children across the world after we've excluded accidental injuries. However, there's also a disparity between high-income countries and lower middle-income countries. Although there's been great improvement in the mortality and morbidity in high-income countries, mortality and morbidity remains at 20% in lower middle-income countries. There is a huge disparity between the two. A lot of studies were conducted during the COVID-19 pandemic to investigate its impact on adults. For example, this study done at the University of Oxford focused on adults with neuro-oncological tumors. The COVID surge studies, once again, focused on adults with oncological tumors. However, this continuously missed one of the largest patient populations suffering from cancer across the globe, children. Therefore, we launched the COVID PEDS cancer study to investigate how the COVID-19 pandemic had impacted children with cancer, and specifically how it impacted their mortality at 30 days, 90 days, and 12 months, what complications were ensued, and what treatments were changed. The steering committee contained eminent surgeons across the globe who helped us formulate the protocol, formulate the plan of delivery of the study, and also organize the study for us as well. The protocol was published, and it changed the primary outcome to 30-day, 90-day, and 12-month mortality. We then recruited collaborators across the world, ensuring there was one hospital lead for each different center. We also ensured that we collected data through REDCap to ensure timely analysis of all the data and also ensure data privacy. Each team had a hospital lead, as I mentioned, but also data collectors within the team and data validators to ensure that the data we were collecting were reliable for an international study. We had various different frameworks for eligibility, but the most important point is that the tumors that were eligible based on the WHO framework to monitor the health of children with cancer across the globe. For example, we used tumors such as the Wilms tumor or low-grade gliomas, acute lymphoblastic leukemia, all key tumors for the WHO. Data collected was on baseline demographic data, tumor-specific data, treatments the patients received, and their outcomes at 30 days, 90 days, and at 12 months. We found that the majority of our participants were from lower middle-income countries. As you can see here, we had a breadth of countries involved, 41 in total. The majority of our patients were male. However, this was equally split across both high-income countries and lower middle-income countries. We also had similar ages, but high-income country children did have a higher weight. The majority of our patients were indeed from lower middle-income countries, with 766 patients from that cohort. We found initially the majority of our patients had acute lymphoblastic leukemia, which is a liquid tumor. However, there was also solid tumors that were quite common amongst all the countries' income statuses. In low-income countries, retinoblastoma was second most common. In lower middle-income countries, Wilms tumor was second most common, and gliomas were more common in the upper middle-income countries and high-income countries. The lack of glioma detection in lower middle-income countries and low-income countries may also be due to how hard they are to detect at an early stage, and the fact that it's often high-grade gliomas that present in these contexts. The results showed there was also a higher ASA grade in patients coming from a lower-income country, and that the median time from diagnosis to MDT plan was also longer below the income status of the country. We found that most patients did have their planned treatment, and the planned treatment that was given mostly incorporated chemotherapy. However, we can see that patients in high-income countries were more likely to get chemotherapy than low-income countries. Same for radiotherapy, same for immunotherapy. However, where low-income countries did predominate was in surgery and also in palliative care. We found changes to plans due to COVID-19, mostly in chemotherapy. And we found this most likely occurred if a child was based in low and middle income countries. Even when adjusting for confounding factors, there was a 372% greater odds change for patients in low and middle income countries. Mortality was also greater in low and middle income countries, with, for example, children in low income countries having almost a 44 times greater odds of death compared to children in high income countries. Other factors associated with mortality was the SARS-CoV-2 infection status, but also chemotherapy within 30 days seemed to reduce mortality, as did having more benign tumors and having a lower ASA grade. A similar feature was seen at 90 days, with children in low middle income countries having a greater death rate, and this odds after adjusting for other confounding factors being greater in low income countries, low middle income countries, and upper middle income countries. And once again, mortality being associated with with a higher ASA grade, no chemotherapy, no surgery, change in radiotherapy treatment, and more aggressive tumor types. All in all, this is the largest international cohort study to date to report COVID-19 outcomes for childhood cancers. We found that mortality does differ between low middle income countries and high income countries. This could be due to baseline differences, but we've also seen that delays in treatments and the COVID-19 infection has also driven mortality here. There's hopefully crucial information for public health policymakers to balance the benefits of providing anti-cancer therapy against the risk of SARS-CoV-2 infection. We are now finished our 12-month data collection, and it has been analyzed, and hopefully this data will be out very soon. I also want to thank all our collaborators for who this study would not have been possible. And I want to thank everyone who's been involved in our research capacity building program, as no research study is complete if we don't ensure that future researchers across the world continue building on the existing frameworks that are out there. We're very excited to see the number of clinicians and academics taking part in this across the planet. If you've got any more questions, feel free to reach out to me. Thank you so much. It was a pleasure talking to all of you.
Okay. Hi, everyone. This is Tamina from Chittagong, Bangladesh. I'm going to share with you our experience of dealing with children's surgical problems during the second wave of COVID. Next. The months were May, June, July. We have the peak incidence of second wave. We saw 604 patients during these 3 months and operated on 271 patients. Male and female ratio were 2:1 almost. 181 was male, 89 were female, and we have 1 DSD patient. Neonates were 26, infant 62, toddlers 67, children 101, and more than 12 years of age were 15. Next. We did not operate on confirmed COVID cases. We postponed those cases for later surgery. And delay in surgery occurred if there is family history of COVID, when the patient's parents could not have any transport. And also it became very costly during this COVID period. Parents have lost their jobs. And of course, lockdown influenced all the status of life. and many families were afraid of bringing their children for surgery during this pandemic period. And the COVID test was not widely available during this time, and it was also costly for our people. And many parents did not want to do the COVID test on their children. And many of our outdoor procedures like dressing, repair of cut injury, release of tongue tie, chest drain, introduction, removal of chest drain, removal of digestion, incision and drainage of abscess, circumcisions, which were usually done in outpatients. But during the COVID situation, outpatient was closed and these patients were shifted to the main operating room. We, among the 271 operations, elective were 150, emergency were 121. The electives, because many outpatient procedures were included in the electives. And morbidity and mortality of these patients, according to Clevy and Dindo classifications, 5 patients were in grade 2, 7 patients in grade 3, and 10 patients died. During this period, our 11 patients acquired postoperative COVID-19 infection. They needed transfer to pediatric ICU. 7 recovered by the grace of God, but 4 died. And this is our experience during the second wave of COVID. Thank you.
Colleagues, good morning, good afternoon. I'm going to talk about mitigating the impact of COVID-19 on children's surgery, Uganda experience. I am Sekabira John from Kampala, Uganda. Since COVID-19 being declared a global pandemic, the first case of COVID-19 was only recorded in Uganda in March of 2020. And as the pandemic spread across the globe, Uganda, the health infrastructure held first initially. And after a whole year, by March 2021, with a population of 44 million, we had recorded relatively low numbers of COVID, and we had only 334 deaths. This feat was only achieved by developing health systems and community responses created to fight other infectious diseases like HIV, TB, malaria, and Ebola. A robust network of laboratory surveillance systems combined with well-trained human resources, including epidemiologists, enabled the successful rollout of contact tracing, testing, and isolation. A nationwide lockdown was declared in April 2020 when all the borders were closed and only allowing cargo trucks and international passenger flights were all stopped. Vehicle movement were stopped, only allowing essential workers to move, which included health workers, and everybody was agreed to stay home. Gradual ease of lockdown was only made after 3 months, that is in June 2020, allowing initially private cars and later on public transport, but with restriction of passengers. Almost the entire country was open, and the second wave hit the country in March 2021, when again another lockdown was declared. The third lockdown did not take place during the third wave of Omicron, which took place in November 2021. The response was strict. After the lockdown, a task force was created where organizations donated funds and a lot of money was collected and with supplementary budget was first passed for procuring vaccines, PPEs, and the construction of ICU facilities, which included improving oxygen supply to hospitals. Luckily, the new renovated Mulago Hospital was still vacant with 28 ICU beds, which were all rolled out, including 100 general beds, which could be also fitted into high dependency units. A field hospital was opened in a football national stadium with 200 ICU with 200 beds, and the COVID treatment units were opened in all 10 regional hospitals. In summary, the impact of COVID on the health systems in the country can be summarized by accumulation of a big backlog of surgical cases in the entire country, which included pediatric surgical conditions. And a number of health workers became sick, which unfortunately one of the few pediatric surgeons in the country succumbed to the disease in June 2021. As of mitigating the impact of COVID-19, strict observance of SOPs was implemented in all the clinical areas. During the peak of COVID-19 waves, all elective surgeries were suspended. A number of staff in all clinical areas were reduced to a bare minimum. Tutorials and seminars for all students and fellows were conducted online, mainly via Zoom. Testing was initiated for all elective cases after the ease of lockdown and a few selected emergencies. We started using HMOE filters for breathing circuits on anesthetic machines. With the help of friends, especially from income countries, which was spearheaded by Dr. Dorukos Geddes, we managed to get assistance and procured some PPEs, and also organizations like Kids OR initially sent 3 cartons of N95 in 2020, and later on facilitated the donation of by the Scottish government of 2 containers with the PPEs, which has been shipped and en route to our national medical stores. We organized the 2 surgical camps to clear some of the big backlog of cases, and we encouraged the health workers to be vaccinated. Thank you for listening to me.
Thank you, everyone. Thank you, everyone, for this beautiful session. COVID-19 seems to have affected a lot of places and affected our practice and our care for children with surgery and requiring surgery and children with cancers. The first question goes to mitigating the effects in India of COVID-19 in India, and asks, over the past year, do you think the backlogs have improved or worsened in your setting? Essentially, is this still an ongoing issue?
Thank you.
Then that's the first question. The second question says, what efforts could be made to address the surgical backlog at your facility due to the pandemic?
Thank you. This is Brisha speaking. So my talk was not related to India. It was related to entire GICS membership. So the data relates to all the countries. In terms of India, I think the backlog has improved because all the surgical facilities are functioning and have been functioning off and on for last 1 year. And at least in our institution that we know is that they have actually increased our surgical list by almost twice. And that has helped. And our backlog now is like our most of our waiting lists are now less than 1 to 2 months. So it has improved.
If there are no further questions, shall we move on to the next session then? All right, so I think.
There are no other questions. We can move to the.
All right,
sorry,
excellent.
there was the second question that says what efforts. Oh.
Sorry. Go ahead, Bami.
The second question, it talked about what effort could be made to address the surgical backlog at your facility due to the pandemic.
I think a lot of efforts have been made to address the surgical backlog. And one of it was that as soon as even though our operation theaters are closed when the infection levels are high in the hospital, there is a very close watch kept on it, and almost decisions are made day by day or week by week, and the theaters are reopened. The number of surgical facilities available was increased, and in our institution, they also provided, different levels of free treatment for the patients. So a large number of patients could get free treatment. In addition to that, the government themselves have actually provided, many state governments from where the patients are coming to Vellore have opened up free treatment so the patients could get treated in our hospital and the government would pay the bills. So this was a government fund support for the patients. In addition to that, to improve the travel and everything else, for instance, in our state, the local travel by government buses has been made free. So there have been a lot of initiatives done by the government themselves in India, which has improved which has contributed to the improvement of the medical and surgical care. And in our state, for COVID patients, the government was picking up the bill. So they had set a limit and they were picking up the bills. So there were a lot of things like this done.
Okay, thank you, Dr. Maduri. I don't know if any of the other speakers have anything to add to Dr. Maduri's response. In the absence of any other response, we can move on to the next session. I don't know if Dr. Seed have any other thing to add.
No, thank you, Bunmi. This has been a great session, and thank you to Dr. Butler and everybody else on her team that's been organizing this really awesome meeting.
Yeah. Thank you.
All right, Sarah and Gabriella, you can introduce yourselves at this point. We'll move on to the next session.
Yes, thank you very much. My name is Sarah Greenberg. I'm a pediatric surgeon at Seattle Children's Hospital and assistant professor of surgery at the University of Washington in the US. And I am honored to be able to have the opportunity to co-moderate this panel with Gabriella Hyman, who is a surgical medical officer at Chris Hani Baragwanath Hospital and a PhD candidate at Wits University who is engaged in local INSOAP work as well. And we look forward to hearing from our panelists.
I would like to thank the organizers of GICS for inviting me to speak at this webinar and for inviting me to share my experience on Pakistan's INSOAP work so far with the group. My name is Lubna Samad. I am a pediatric surgeon working in Karachi, Pakistan, and I have no disclosures. For those of you who are not familiar with Pakistan, it is a country of over 200 million people located in South Asia, with over a third of its population in the under 15 age group. The need for a national surgical plan arises given the fact that there are more deaths taking place due to surgical conditions in Pakistan as compared to all infectious diseases combined. We have a high maternal mortality rate, and one of the contributors to this high rate is the lack of surgical care for complications of obstetrics. And there is an annual deficit of over 17 million procedures. The country has an SAO density well below the target laid out by the Lancet Commission on Global Surgery, and there is an inequitable distribution of workforce and resources, with most of the surgeons and anesthetists congregating in the urban centers, and this is most stark at the secondary level. In Pakistan, we started the ENSO process way back in 2015 with initial consultations with representatives of the Ministry of Health. This was at the outskirts of the World Health Assemblies held in 2015 and 2016. And then finally in 2018, when there was a positive engagement by the representatives of the Ministry of Health at the World Health Assembly side events. Subsequently, in Islamabad, we continued these discussions, and a letter of understanding was signed between the Ministry of Health and Indus Health Network. A national steering committee and a technical working group were notified, and subsequently a national stakeholders conference was held with international participation with the WFSA, PGSSC, and Emmanuel Ame represented the children's constituency at this meeting. We then developed a consensus statement at the end of this meeting, which then was shaped into an NVSC draft, which is the National Vision for Surgical Care document draft. Subsequently, a series of provincial stakeholders engagement workshops were held, and after their feedback was integrated into the draft document, the final NVSC document was launched in July 2021 in Islamabad, and this was co-hosted by the Ministry of Health and UNITA. After this document, which highlighted the vision of NVSC, was for all Pakistani citizens to have access to safe, timely, and affordable emergency and essential surgical, obstetric, and anesthesia care services so that they may live healthy and productive lives. This vision complemented Pakistan's national health vision of providing healthcare to all of its population. However, the National Health Vision did not specifically mention surgical care, and therefore the NVSC document acts as an addendum to the National Health Vision. The highlights of this document is to provide a framework to optimize surgical care delivery, and the strategic priority areas cover the 6 domains of governance, health financing, service delivery, infrastructure, health workforce, and health information systems. We recognize that Pakistan has autonomy at the provincial level for several areas, including health, and therefore the implementation of this program has to take place at the provincial level. This document also identified indicators and time-bound targets for implementation. We've now moved into the implementation phase using the Universal Health Coverage Essential Package for Health Services strategy, which is a collaboration between several groups, including the DCP3 Network Project, World Health Organization, and the London School of Hygiene Tropical Medicine, and the Health Analysis Unit at the Ministry of Health. The approach towards this implementation is to look at the burden of disease data and health needs assessment, which has been done, and a series of consultative workshops were held in the country, following which a report prioritized the health needs for Pakistan. The costing of these prioritized interventions was conducted between 2019 and 2020, with some delays due to the pandemic. And finally, a national discourse was held in February and later on in the year of 2020. A pilot of this EPHS was launched in Islamabad Capital Territory. And again, the delays due to the pandemic led to the work really swinging into place in late 2021. The surgical component of the essential package of health services includes 46 emergency and essential surgical procedures, which are distributed between the primary level, the first level, which has the most surgical procedures, and the tertiary level. It is important to note that although there are 4 surgical procedures that are specific to children, for example, cleft lip and cleft palate surgery, we have made sure that we have added on 19 procedures. For example, a laparotomy in a neonate is very different from a laparotomy in an adult. Similarly, a colostomy in a neonate requires a different level of care than that required in adults. And therefore, we have added on 19 children-specific costing interventions for this EPHS packages. We're still hoping to swing into the implementation at the secondary level in 2022-2023, and I look forward to sharing our experience at the next GICS in this regard. Thank you so very much for your time. Bye-bye.
Good day, everyone. It's my pleasure to share with you what we have been doing with the National Surgical Plan in Nigeria. And my focus for this discussion is going to be about our current ongoing implementation of the National Surgical Obstetrics and Anesthesia and Nursing Plan for Nigeria. So the plan for Nigeria was created and launched in May 2019. And I think one of the important things about the plan for Nigeria is that the plan is unique in a number of ways. One aspect was the fact that that was the very first time the optimal resources for children's surgery was used to facilitate the inclusion of children's surgery in any country's surgical plan. It's also the first plan to prioritize and include children's surgery, specifically in the ENSOP, and also the very first plan to prioritize and include nursing in ENSOP. And just to highlight some of the key findings during the development of the plan as relates to children's surgery, one of the facts is that in terms of workforce distribution, what we found that there was really very severe inequality across the country, even though, yes, by the end of 2021, we had 122 pediatric surgeons for a population of more than 200 million. Nearly half of these are below the age of 15 years. And our pediatric surgeons density really is so low, 1 to more than 700,000 children below the age of 15 years. You can compare that to the recommended density from APSA, which is 1 to 100,000 population of children below 18 years. The other aspect that we found was that children's specialization across anesthesia and other surgical specialties was quite limited. And across the country, the map you see there, the darker the darker the coloring of the map, the longer the distance and the number of hours the children need to spend before they can get to a location where there is both a pediatric surgeon and anesthesiologist that is able to handle children's surgery. So the summary of that is the fact that the percentage of children residing within 2 hours of a health facility that can provide surgical care for children range from less than 2% to 30.5%. And in 3 states, really, only a maximum of 4.8% of the population had access to a facility that can provide children's surgery within 2 hours. In 12 states, that was about 14%. And in 8 states, that was about 22%. So you can see that the large parts of the country, children in large parts of the country really don't have access to proper surgical care. We also found significant infrastructure gaps. There is no functioning public children's hospital in the country with a population of more than 200 million. The public hospitals, most of them really actually have no children's operating room. Equipment and supplies for children's surgery are quite limited, even in the very large centers. So in terms of implementation, we are currently implementing the plan, and we recently published the current status of our implementation just late last year. We had an implementation meeting in February 2020, and the outcome of that implementation meeting was the fact that we created entry points to facilitate the implementation. One of the key entry points was children's surgery. Others were nursing, workforce training, life support, safety, and research and data. And we started a pilot implementation. The Ministry of Health in Nigeria took a number of actions to facilitate implementation. They actually deployed the implementation planning meeting. They have created a surgical plan desk at the Ministry of Health. What that means is that the surgical plan is now at the center of the Ministry of Health. So anything they are doing regarding healthcare in the country, surgical care will be included. They also created an implementation committee. And to facilitate the implementation, they signed MOUs with development partners. The first one was with SmileTrain, which took up the key entry point of children's surgery and activities related to scaling up children's surgery. So most of the implementation that we've presently been able to achieve are based on our collaboration and funding support from SmileTrain. So the first one of them was life support training, basic life support, and a pediatric advanced life support training. We've trained 144 providers, mainly pediatricians, pediatric surgeons, and other children's surgery providers. And this is being gradually stepped down to begin to scale up the such life support activities across the country. In order to strengthen surgical safety, nurses are being trained in a program we call Nursing Care Saves Lives, which was actually developed by SmileTrain. And the focus is on basic life support, perioperative care, infection control, and nutritional care of children. And the training we have done so far included a comprehensive 5-day hands-on training, and there was also an online, a virtual training. So 24 nurses across the entire country have been trained hands-on, and about 900 other nurses also participated in the virtual training. This training is already being gradually stepped down across the country by those 24 that were trained. Actually, the 24 were meant to be trainers. Now, in terms of research, one of the aspects that SmileTrain is supporting us at the moment was to create a cleft and surgery electronic registry. This is an initial 5-year plan or focus. And in order to ensure that the plan and the registry is sustainable, we are using a purpose-built electronic platform, which is both web-based and also based on Android and iOS, so it's available for phones and handhelds. We have paid data collectors and data validators. They are paid to do that job, so we are not putting anybody on clinicians to collect data. There's a paid research assistant, statistic analyst, a database manager, and a research consultant. We started the registry initially with capturing cleft lip and palate patients and cleft lip and palate surgery, but this is being gradually scaled up to include more centers across the country. But our end point is that we are going to get to a point where that registry will become a birth defects registry, and we'll also get to a point where we actually begin to capture population-based data. So I'll just show you. So this is what the registry started not long ago. So at the moment, this is a live a live data. This is the dashboard of the registry as at a few hours ago. So at the moment, we just have 407 patients captured, but the platform enables us to do all kinds of things. We can monitor, track the patients, we can follow up, we can recall them on different aspects and components. I think one of the important aspects that we are also implementing at the moment is strengthening research capacity. And we've conducted some trainings to ensure that surgical providers, especially children's surgery providers, are able to conduct high quality research. They're able to write good grants applications and also publish their manuscripts. At the moment, we've trained 36 providers, surgeons, and surgeons, anesthesiologists, and nurses from across the country. We've trained 36. This looks like a small number, but the aim is that we will progressively begin to step down so that those who have been trained can also deploy similar trainings in their respective locations. And we're also hoping to scale this up. We are just completing the second batch or second round of training. So this is really helping to scale up research capacity. In terms of scaling of children's surgery infrastructure, which really is a major gap in Nigeria, GICS OR has provided 2 operating rooms in one of the tertiary hospitals in the country, and SmileTrain, as part of their collaboration with us to implement the ENSO, they are collaborating with, working with GICS OR to provide more children's operating rooms across Nigeria. At the moment, they've provided for 3 other hospitals. So we now have 4 hospitals in Nigeria that have children's specific operating rooms created by GICS OR and SmileTrain. And efforts are presently ongoing to create at least one national children's hospital. We are hoping that in the next few years, we should be able to achieve that. But there are threats to what we are presently doing. One of it is the fact that we are having very significant workforce flight. In the last few months, about 7 pediatric surgeons from that 122 that I indicated earlier on, about 7 have been lost to high-income countries and the Middle East. A large number of nurses, both pediatric trained nurses and operating room nurses and other nurses, have been lost to high-income countries and the Middle East. Large numbers of our anesthesiologists have also left. In fact, some parts of Nigeria are unable to provide surgical care at the moment because they are simply not, anesthesiologists are simply no more available in those parts. And many more are likely to leave in the coming months and years. What do we do? That's a discussion that is presently ongoing. Funding remains a challenge, but we are, our Ministry of Health is working to collaborate and partner with other funding agencies to take up other entry points to help in implementing the plan. But I think the bottom line is that we need to sustain and increase our advocacy and engagement with policymakers, public health groups, and funders to make sure that we don't drop the ball anywhere, that we will continue to implement the plan progressively. I think one of the things we've realized is that it's simply not possible to take the entire 5-year plan and say we are going to implement it at once. No, and that was the basis for creating the entry points. So hopefully we should continue to make progress. So this is just a summary. The recent paper that we published regarding our implementation of our ENSO. So this is just a summary of exactly the different components that we are presently implementing and what the endpoints are. So thank you so much for listening. I'm open to questions. Thank you.
Good afternoon. This is Dr. Sharif calling from Liberia. Hello? Hello.
Hello, everyone. My name is Liz McLeod, and I've met many of you over the last few years. For those of you I haven't, I'm a general paediatric surgeon from Melbourne, and I've worked with RACS for many years in the Pacific, and more recently have been consulting for WHO WIPRO. Seems like a lifetime ago that we were in Johannesburg. So much has happened, and this year, is, of course, we're missing our dear friends and colleagues. More from Marilyn and the team on that later. I'd like to update you on what's happening in the Pacific with respect to surgical planning. Much of this work has been done by our colleagues in the region. I don't know if Basil is on, but he and the team in Vanuatu are progressing their NSOAP. I don't know who else is on, maybe Ben Yapo from PNG. The work has been supported by Key Park's lab at the Harvard PGSSC, in particular, two fellows, Rennie Quinn and Zach Fowler. We're very fortunate to have strong surgical leadership in the Pacific and strong advocacy. Following WHO 68, we collected the Lancet metric for 14 countries. And then at the 13th meeting of the Pacific Health Ministers in 2019, there was agreement to commence the NSOAP process following the lead of African nations and Pakistan. A side event at RCM 70 in 2019 was an opportunity to present the agenda for safe and affordable surgery in front of the regional director. Although I'm not sure if it was the side event or the dance break by Minister Wanganabeti from Fiji that clinched it, but we managed to get safe and affordable surgery on the agenda for RCM 2020, at which time there was unanimous adoption of the action framework, and last year we've been able to commence implementation. We know that surgical systems are complex, and to work well, we need effective functioning of multiple domains. They're not simple like vertical programs for vaccination, for example. Of the data that we collected a few years ago, no real surprises. We showed critical workforce shortages and poor access in many countries, and all the problems associated with small island developing states, for example, small population sizes, archipelagic and mountainous geography, and small-scale economies. And just to highlight Solomon Islands, very limited access for many of the population, and very low surgical workforce and surgical volumes. I just wanted to, in the NSOAP process, I just wanted to mention stakeholder engagement. This is the opportunity to be really inclusive. We must have the Ministry of Finance on board right from the word go. Fiscal space for surgery is tight and closing. For example, hard border closures in the Pacific over the last couple of years have led to a massive loss of GDP and also the diversion of resources for the pandemic response. Around 65% for Vanuatu and 21% at GDP loss for Fiji in 2020. So we need to be strategic and look for synergies between surgical systems and disaster risk reduction, for example. Sudden onset disasters in the Pacific are extremely prevalent, so we need to be thinking about trauma and emergency care systems and to frame strategies in terms of DRR and also pandemic response, thinking about workforce and HDU capacity, for example. And of course, we know the burden of surgical disease in our patients globally. And this is the opportunity to include our patients in national plans. So this must happen right from the start. So make sure that you're at the table during the planning process. Of the 5 countries agreed to pilot the NSOAP process for the Pacific, progress to date. Tonga have completed their first draft, which is ready for review. But of course, there's been disruption due to the volcanic eruption. Fiji have completed their stakeholder meetings, but the process once again has been disrupted due to their severe COVID wave last year. Vanuatu, Cooks and Palau have completed their situational analyses, and hopefully we'll be able to commence their stakeholder meetings this year. Hopefully Basil is on and can comment during the discussion. We've learned a lot so far, in particular the importance of a local champion or champions to drive the process, the importance of a very early Ministry of Health and Finance buy-in, and also to develop to use a really grounds up and inclusive approach, working towards a shared vision in alignment with the action framework. And this is Tropical Cyclone Harold, last year about to make landfall over Santo in Vanuatu. Strong surgical systems are part of the generic resilience that we need for complex risks such as those posed by climate change. And unfortunately, the exogenous shocks that everyone is going to have to deal with are just going to keep on coming. So really important that we are as prepared as we can be. And that's all from me. Thank you.
Thank you very much to our panelists for those fantastic presentations and for their pioneering and critical work in integrating children's surgery into INSOAPs and implementing those plans. There are a lot of comments in the chat box thanking you for this work and highlighting its critical nature. There's a number of questions as well, and Gabriella will start with posing them to you.
Great. Thank you, Dr. Greenberg, and thank you to all the contributors to the session. We've summarized some of the questions from the chat, and we'll start with question number 1, which is, do the current NSOAPs or NBSCs include antenatal diagnosis programs for congenital anomalies as a strategic point in pre-hospital management of patients? So I think that's addressed to all 3 panelists. And if we can perhaps keep the answers, we can try to get through all 4 questions. Perhaps we can answer in order of presentation. Dr.
So maybe if I can go, yeah, if I can go. So for the Nigeria plant, so the obstetric component, so we are at the moment trying to break down all the different components into specific entry points because of the realization that it's going to be difficult to just take whole segments. So one of the aspects that we are breaking down to at the moment is prenatal diagnosis. And in the coming months, we are going to be embarking on some training of midwives, traditional birth attendants. And then in addition to prenatal diagnosis, we are combining that with early recognition of birth defects at the time of birth. Bumi, who is on the meeting today, has been really leading a lot of the efforts regarding early diagnosis of birth defects. So in the coming months for us, that includes prenatal diagnosis and early diagnosis. Thank you.
Should I go? This is Lubna. Can I go ahead with a response to the same thing?
That would be fantastic. Thank you.
All right. Great. So the way the NSOAPs in Pakistan have worked out is that we have managed to get a commitment from the federal level government to allow for a focus on surgical system strengthening to be an integral part of the UHC model that we're implementing in the country. And when we get down into the nitty-gritties of actually delivering care, our focus remains on within the UHC package, it remains on the 46 surgical procedures that we've identified through the DCP3 evidence. We're using that as the backbone of our UHC program. And the level of detail that your question refers to, referral to a pediatric surgery center, perioperative care for the surgical neonate, is not part of that plan as yet. However, we do have a strong emphasis on integrating care between levels. So building strong referral systems between PHC to first level and on to tertiary. And I guess the specifics of surgical neonates will be covered in that recognition and transfer system that we're hoping to develop.
Thank you. The second question from the audience is, what steps should or can be taken when integrating NGOs or surgical missions into the INSOAP service delivery model? Is this something that should be included?
So if I may, okay, sorry, Lubna, go ahead.
Thank you, Emmanuel. So I think our problem in Pakistan has continued to be facilitation of travel to the country for over the past couple of decades for a variety of reasons. Pakistan is not the easiest country to travel to. And therefore, any system that relies on surgical missions or people coming from outside the country to deliver care on a regular basis here is fraught with complications and last minute cancellations because of a red warning or something from a country. And the other concern really is, as we've seen during the pandemic, the travel between countries has been exceptionally difficult all around. So I think while technical input and advice from international missions and NGOs is always welcome, that's really not the input that we would rely on for day-to-day service delivery. Again, Pakistan is different from a lot of other countries because we have a very large group of medical colleges across the country, both in the public and private sector. We graduate thousands of people, medical students on an annual basis. And the challenge really is not that we don't have enough SAO coming into the workforce. It's the urban-rural challenge that is a much bigger issue in our country. So our strategies have to focus on how to ensure that trained specialists are able to work in more remote locations as compared to congregating into the urban areas.
So if I may add, so for us in Nigeria, the main focus really is how we can work with the NGOs and development partners to support implementation, because in reality, the healthcare budget available to the Ministry of Health really is too limited to really be deployed into significant implementation. But the main challenge is actually getting the NGOs to be involved. Our experience showed that most NGOs are very reluctant and a little bit apprehensive of getting involved in anything related to surgical care because of the fear that the cost is going to be much. But what we have done is to work strongly on our engagement with them and to try to get a champion within the NGOs. And I think that once they catch the same vision, it becomes a little bit easier. And once you get one NGO, you get their attention, it also has a multiplier effect. It becomes more easier to begin to work with other NGOs. And for us, because of the previous work we've been doing with Smile Train on clefts, I think it was possible to get them in, and they have been extremely supportive. We wouldn't have been able to initiate implementation in the first place without Smile Train coming in. And that now is helping us to begin to get other NGOs to be involved. Thank you.
Could I just make a comment for the Pacific, which is that because of the size of many PRC population, many countries will never be able to achieve independence of surgical workforce, and there'll always be some degree of reliance on visiting medical teams, and that's just the fact of the matter for the Pacific. But if Basil's on, I'd really welcome his comment, both on the previous questions around antenatal screening, congenital abnormality care, and also dependence on visiting medical teams. I'm not sure, Basil, if you're on. I know it's not a great time for us, so but I did see your name. Maybe he's with us in spirit only. Anyway, let's move on if Basil's not around.
Great. Thank you for your responses. I think this discussion is very pertinent and being well received by everybody in the audience. The next question was a more technical question to those who have developed ENSO plans. What strategies were employed to integrate children's surgery into NVC or NSO-ANP, and so specifically any strategies that deviated from the UNITAR ENSO manual, if any, were employed?
Emmanuel, do you want to go first on this one?
Right. Yes. Thank you. So, so for us, I think the main strategy was getting our colleagues on the ENSO team, because even our colleagues who are not children's surgery providers really did not see the strategic importance of incorporating children's surgery. So that was the first step, was convincing them that children's surgery really is not the same as adult surgery. And that took a lot of interactions and engagement, and providing them with some of the data that is available in Nigeria and also available globally. And once we were done with that, we were then able to convince policymakers at the Ministry of Health. But I think one important aspect was the fact that we had a number of pediatric surgeons and children's surgery providers that were part of the team. So it was easy to work from inside. And that is why I think, as all of us as children's surgery providers, as we should get involved with the ENSO process in our respective countries. If we don't do that, it's going to be difficult to get children's surgery included. So for me, I think that was the most important aspect, the fact that we were directly involved and we could work from inside and begin to convince everybody. Thank you.
Thanks, Emmanuel. So at our end in Pakistan, as I said, we were using the DCP3 evidence to create the universal health coverage packages. And in that, we were asked to develop the requirements to implement surgical interventions at the first level and at the tertiary level. At that time, we realized that there were only 4 or 5 procedures that are children specific. For example, surgery for cleft lip and palate, and anorectal malformations, etc. But a vast majority of surgical procedures which did not specify age group of the patient were being looked at in the adult context. So for example, when you looked at a laparotomy, it was what would you need to be able to perform a laparotomy at a first level hospital. At that point, we basically made it clear that we were going to take all of these surgical procedures as A and B costing. For example, A would be for adult and B for baby, just to keep it simple. And a laparotomy for an adult could well be done at a first level. However, the same procedure in a neonate would need to be done at a tertiary care level or a place with a NICU and a pediatric anesthesia and backup. And thus we were able to have 19 procedures which had pediatric specific add-ons, as I have explained in my talk. What that allowed us to do is recognize at the process level, when we were costing it out, that you could not cost out a colostomy as a uniform procedure. It had to be looked at very differently in adults and children, and very much in line with what the OREX document supported. Where should that procedure be carried out? What were the resources needed for that particular procedure to happen? And that's really where we specifically put in a child-specific, a child-friendly agenda to the entire structure of the implementation.
Thank you very much. We have a number of other questions, but I think we are dealing with time restraints and need to end this session. I think we should be able to address some of the additional questions with our panelists offline, but I want to thank all of them for sharing their experience today and for this incredible work. There's a lot of gratitude towards you and these efforts in the chat box right now. Thank you.
Thank you so much, everyone, for the last few hours that we've all spent together. I think it has been very engaging. I've thoroughly enjoyed it, and I hope that you all have enjoyed it too. So we are coming to the end of the specific sessions. We will now be moving to the breakout sessions, the specialty breakout sessions. Marilyn is going to be giving some additional information regarding those sessions, but I also want to emphasize that one of the things that has happened with the OREX document is that countries have used it to incorporate children's surgery into ENSOP. Countries have used it to evaluate children's surgery services in specific areas, and we are beginning to realize that we think that we are at a point where we need to revise the OREX document based on the experience that we've had so far. So we, in addition to focusing on other things, a significant part of what we want the breakout groups to do will be to begin to look at the OREX document and begin to see what in their specialty sections need to be revised, so that we are hoping that at the end of our meeting tomorrow, we should be able to have some direction about the kind of revision that we want to make. So Marilyn, over to you for the specific details.
Thank you, Emmanuel. I just need to provide a few, let's see, I don't know what I'm sharing. Let me see, share screen. What I want to do is share this one. And I want to first thank our moderators today, and specifically our trainee moderators, Chisholm Adebwe, Bunmi Majid Godunwi, Gabriella Hyman. Guy Jensen mentioned in his talk things that go behind the scene. There have been hundreds of WhatsApp messages that have gone on behind the scenes, and a lot of those have been with Greg Klazura and Katrina Morgan, who have helped to monitor the chat and help feed some of the questions to the monitors during the sessions today. So many thanks and kudos to them. There was some additional help before the webinar began. Megan Vu and Greg Klazura helps do some of the recordings of the videos, and Tina Bio, a UCSF medical student, has helped with some of the review of the videos. In terms of the logistics, Guy Jensen rallied together all the trainees and was able to recruit several of them to be the monitors, and many thanks to him. Sabina Siddiqui made all of the introductory slides that you've been seeing today, and they're beautiful, and greatly appreciate her work. But I'll tell you what, this webinar would not happen if it were not for Ruth Laverde. Ruth has been here all day today playing the videos. But there was more to it than that. She reviewed all the videos and streamed them together into one video for each session and put in all those introductory slides. So she's done an enormous amount of work for us, and we need to all thank her as many times as we can, because without her, this would not be happening. So with that.